Dear colleagues, dear EBC friends, my name is Goran Stankovic, and on behalf of the European Bifurcation Club, I wish you a warm welcome to all of you. As the situation with the COVID-19 pandemic is still evolving worldwide, we would like to extend our thoughts to all of you facing challenges both in your professional and private environments. Given the present circumstances and the official recommendations, we have decided to cancel as a physical meeting EBC 2020, and we follow the suit of other major cardiology congresses to introduce a digital edition, bringing high-quality professional education to the home computers of a wide audience of practicing clinicians. Our decision was made in the best interest of our faculty, attendees, industry partners and staff in order to ensure their health and safety. A big thank you to all EBC board members for hard work in designing and preparing this year's online program. Our focus this year will be to present the most recent developments and publications in bifurcation PCI in 2020 and discuss left main intervention, pitfalls and troubleshooting in bifurcation PCI, and the role of imaging and simulation in enhancing bifurcation and left main PCI outcomes. Welcome to EBC 2020. Dear colleagues, dear EBC friends, warm welcome live. I'm in Belgrade and I'm chairing this session with my teachers and friends, Dr. Yves Louvard and Dr. Patrick Serruys. And on behalf of the organizing committee, it's my immense pleasure to declare EBC 2020 online meeting officially open. Traditionally, we start each year with the news session, and I hand over to Professor Patrick Serruys to start the session.
I think I would just say a word that I admire the resilience of the club by going through during this pandemic period.
Thank you very much, Prof. Serruys. We worked as a team, the whole board was involved and everybody contributed as much as he could. And the panelists for the first session are actually representatives of all worldwide bifurcation clubs. Bon-Kwon, welcome. Yoshinobu Murasato, Rajiv Bhagwat, Dobrin Vasilev, Vlad Dzavik, George Dangas, Tanveer Rab, Carlos Uribe, and Ricardo Costa. And the first speaker today is my friend Maciej Lesiak, and he will present the most important publications in 2020. Maciej, please start.
Good afternoon. Let me present the latest data you can find in literature on bifurcation. This is my potential conflict of interest. So this is what I found, the numbers, more than 130 papers in between October 2019 and October 2020, mostly related to the stenting technique, novel devices and clinical outcomes, but also to bench models, imaging and complications and the case reports. There are three important studies I will not discuss now because they will be discussed in detail later in this conference. So let me start with a bench study performed by Gabor Toff and colleagues when they investigated the new culotte stenting technique, double kissing culotte, and compared with decay crush and regular culotte. So that's the principle of this technique. Basically, you perform final kissing inflation twice after each rewiring. So what they found was that the duration of decay culotte was significantly lower as compared to decay crush technique. On the micro CT analysis, they found that the decay culotte changed the cybranch angulation significantly less as compared to decay crush. And also they found on the OCT analysis some signal of improvement in terms of better stand apposition, at least in some part of bifurcation like proximal main branch or the roof of the polygon of confluence. So They concluded that double kissing approach can significantly facilitate the performance of the culotte technique, and DK culotte may be superior not only to conventional culotte but also to DK crush technique, which of course has to be confirmed in a clinical study. So this is a great anatomical paper when the authors investigated the anatomical attributes of clinically relevant diagonal branches by using MPI and computer tomography. So what they found was that myocardial territory supplied by the diagonal branch is determined mostly by the circumflex dominance and also by number of branches and the dominance among the diagonal branches. So you can appreciate on the right-hand side that if you have a single occluded diagonal branch and there is no circumflex dominance, then the ischemia will be more than 50% of myocardial mass. Whereas if the same single diagonal is occluded, but there is a dominance of circumflex with a large obtuse marginal branch or intermediate branch, then the ischemic region will be much less than 10%. So not every diagonal branch, not every side branch is clinically important. This is the study checking the different stenting technique, investigating what stenting technique is the best for complex bifurcation lesion. Just a network meta-analysis, 26 randomized studies included. And the answer is already in the title. So what the authors found was that DK crush, as compared to other technique, is clinically beneficial to the patient. They found a significant reduction in device-oriented clinical events, which was also confirmed by this Bayesian random effect model. So they concluded that in the management of true coronary bifurcation lesion with a two-stent technique, when a two-stent technique is required as an upfront strategy, the DK crush perhaps will be the best and should be preferred. Now, two interesting papers trying to ask the question of the significance of kissing inflation. The first one coming from Excel study with long-term 4-year observation. As far as for the one-stent strategy, no big surprise that they did not find any significant impact of final kissing balloon on the outcomes. For two-stent technique, I think that's a surprise. They didn't find any advantage of performing kissing, which may be presented by those two Kaplan-Meier curves. So if you look at the left-hand side, there is a single stent strategy. You can observe even some harm by kissing, whereas on the right-hand side, two-stent technique, there may be some advantage, which was not statistically significant in the study. So the authors conclude that routine final kissing balloon inflation may be not necessary after left main bifurcation PCI if an acceptable procedural result is achieved. Now is a question, what is acceptable result and how we should measure it. Another study touching the same question, the impact of kissing balloon stenting. This is the study with modern generation stents reported by a RAIN cardio group, more than 2,500 patients. And what they found was generally the same as for the provisional, for the single stent strategy, no significant difference as compared to the outcome. But for the complex two-stent technique, you can appreciate a clear, significant improvement in MACE, mostly driven by reduction in TVR or TLR, which may be also very nicely presented by those Kaplan-Meier curves. The COBIS-3 study, the Korean multi-center registry, more than 2,600 of patients included. And this paper was designed to answer what is the outcome if different stenting strategies are applied for left main and non-left main bifurcations with current generation drug-eluting stent. And what they found was that for left main bifurcation stenting, one stent strategy is beneficial for the patient. So there was a clear benefit if only one stent was used, and mostly driven by target lesion revascularization. No difference as for cardiovascular death or myocardial infarction. Yet for non-left main bifurcation stenting, the authors found no difference. So no significant difference, neither for cardiac death, myocardial infarction, nor for target lesion revascularization. But this study has a couple of limitations. We have to keep them all in mind, that this is non-randomized, retrospective, observational, and the patients with two-stent strategy were more likely to have a complex lesion profiles than those with only one stent. So this is obvious, and we all should keep in mind. And finally, just a glimpse in some imaging studies. The first data come from the novel long-term observation of patients with left main stented with IVUS or without IVUS guidelines. Generally, no big difference between the groups, apart from the TLR. So the use of IVUS at the end of the procedure resulted in a bigger minimum stent area and the reduction of target lesion revascularization. Another study with a big number of patients, more than 11,000, and the data come from the British Cardiovascular Interventional Society database. And they found that in an unprotected left main stenting, the use of IVUS reduced significantly mortality. And what is really interesting is that this benefit was observed very early in an in-hospital phase, but also after 30 days and 12 years. And another great study showing that IVUS is important for the left main stenting, but this study shows that not the IVUS as such, but when you use an IVUS, you should know what you're looking for and what kind of criteria you should meet with this technique. So the authors first developed this optimization criteria, and then they try to follow them. And what they found was that not only just the pure use of IVUS, but just the meeting of those criteria, they call it IVUS pro group, was the prerequisite of obtaining better results for mortality and for left main target lesion revascularization. And this is my last slide, only 8 minutes, so it's not enough to analyze a lot of interesting studies. Just to encourage you to read this paper published by our Asian colleagues with some help of Jens on coronary bifurcation interventions, the Asian view, as well as a great paper, a white paper by European Bifurcation Club on stenting techniques, beautifully illustrated, very practical, and very useful in our daily practice. Thank you very much for your attention.
Thank you, Maciej. So I think we have a panel discussion after.
For this kind of invitation to participate in the European Bifurcation Club meeting this year virtually in 2020. I'd like to present our work entitled Clinical Outcomes Following Coronary Bifurcation PCI, and this is a network meta-analysis approach. My name is Carlos Colett. I'm an interventional cardiologist from OLV Aalst. So what do we have as a background? That we know that despite several randomized clinical trials comparing PCI bifurcation techniques, the optimal technique is still a matter of debate. Provisional stenting has been recommended by the European Bifurcation Club as the default technique for most bifurcation lesions. Nevertheless, as bifurcation techniques evolve, new techniques have been described aiming at improving clinical outcomes. In that sense, recently, the DK crush technique has shown in randomized clinical trials favorable clinical outcomes compared to other PCI techniques. Therefore, we aim to perform a network meta-analysis of randomized clinical trials comparing clinical outcomes after PCI with different bifurcation techniques. And what is new about this approach is that for the first time, we're able to identify the potential benefit of a particular one or two stent techniques instead of the previous meta-analytic approach that combined one versus two stent PCI techniques. So we include randomized clinical trials with patients that underwent PCI bifurcation for bifurcation lesions and had at least 6 months of clinical follow-up. The primary outcome of interest was major adverse cardiovascular events. This is MACE, and these MACE were defined according to each protocol, to each randomized clinical trial. We also defined secondary outcomes that were cardiac death, myocardial infarction, target vessel or lesion revascularization, and the occurrence of stent thrombosis. We estimate odds ratios using a Bayesian network meta-analytic approach. In this approach, we synthesize direct and indirect evidence regarding the clinical outcomes related to that specific technique. First, we apply a random effect meta-analysis for each treatment comparison, and subsequently, a random effect consistency model using network meta-analysis to assess the relative effects of the multiple treatment comparisons using a Bayesian framework as mentioned. All the results that you will see in the next slides are odds ratios with 95% credibility interval. So when we performed the search, this is what we found. 840 citations, and from there we found 21 eligible trials comprising more than 5,700 patients. When we look at how were these patients distributed among the techniques that we investigated, and you see in this network plot that have two relevant information. One is the size of these bubbles, of these circles. The bigger the size, the more the patients that were included in that specific technique. And when we see also the lines that connect these dots, the thicker the line, the greater the number of trials that have compared these two techniques. For example, there are 5 trials comparing the provisional technique with the DK crush techniques, and you see the absolute number of the patients between brackets. The first finding that we have in this meta-analysis is that when we assessed the risk of bias, you will see here in the last column, the overall, we have very few happy green faces. Most of these faces are yellow, which means that the quality of the evidence was moderate. And this is important to bear in mind and to understand the limitations of this approach and, of course, the impact of the overall conclusions. To show you the studies that we include, this is the list of all the studies with the clinical characteristics. This slide is not intended to be read, but I will summarize to you that the mean age of the population included was 64 years old, 22% of the patients had diabetes, and the most used technique in this meta-analysis was the provisional technique in 34% of the cases. When we look at the event rates stratified by PCI techniques and a mean follow-up of 12 months, we'll see that we're talking about a MACE rate that range approximately from 10 to 15%, a range of cardiac death in this population of patients with coronary artery disease in bifurcation lesions of about 1.8 to 3.3%, and you see the overall rate of myocardial infarction that is also has a big range from 2.7% to 10.1%. Most of the variability concerning these endpoints, of course, arise due to the different definitions in these endpoints as assessed in the individual randomized clinical studies. This is the overall finding. This, by the way, was published a couple of months ago in the Journal of the American College of Cardiology, Cardiovascular Intervention, and this is the primary result. So we're looking now at the forest plot of MACE, again, 21 trials, 5,711 patients. Everything that is on the right side of this forest plot means that it favors provisional. It means that all these techniques are compared against provisional. And everything that goes to the left side of this plot favors the technique that we are investigating. For example, if we start by crush, the crush technique, you see that this black line that depicts the 95% credible interval touches the line of 1. Therefore, there is no significant difference between provisional and crush for the outcome of MACE with an odds ratio of 1.23. However, we immediately see that the line of the DK crush is towards the left side of the plot and doesn't touch the unity line, meaning that there is a significant difference favoring DK crush compared to provisional for the outcome of MACE. And how big is this effect? Well, we'll see here the odds ratio showing a 61% reduction in the occurrence of MACE in patients treated with DK crush compared to provisional. When we try to understand where this difference comes from, we will see the 4 individual endpoints that we have analyzed within the study. you will see that there is no difference in cardiac death. You will see that all the 95% credible interval lines touches the 1, meaning that there is no difference in cardiac death. There is no difference in myocardial infarction. However, we do see that the line of DK crush is towards the left, nevertheless touching the line of 1. But when we look at target vessel revascularization, you will see clearly that the advantage of DK crush comes mainly for a reduction of target lesion revascularization, as shown here in this plot and with this point estimate of 0.36%. Finally, we found no difference in the rate of stent thrombosis between bifurcation techniques. We went a little bit further on, and then we started to look at anatomical bifurcation characteristics. And one of the things that we had in our database was the side branch lesion length. The median side branch lesion length of all these studies that you see in the screen was 10.1 millimeter with a interquartile range from 6.3 to 13.9. And I would just like to point to the fact that the majority of the studies showing benefit of DK crush had relatively long lesion length compared to previous study. Nevertheless, the analytic approach that we used was to divide these two group of trials according to the median side branch length that was 10.1 millimeter. And then we performed a pairwise meta-analysis, dividing the trials according to the median side branch lesion length. And you will see here that now we perform an analysis of 1 versus 2 stent techniques in patients with short side branch lesions, and the same thing, 1 versus 2 stent techniques in patients with long side branch lesions. And what we see is that there is no different what concerns MACE in patients treated with 1 or 2 stent techniques with short side branch lesions. However, when we look at these trials that had long lesions, there is a clear benefit of 2 stent techniques over 1 stent techniques. We have to highlight a number of limitations that our analysis have. 1, we were unable to obtain individual patient data for all studies. Therefore, we perform a study-level meta-analysis. Second, 6 of the studies exhibit high risk of bias, and these were the phases that I was showing in the previous slide. This was mainly related to routine and geographic follow-up, which may have led to a higher rate of repeated vascularization. Third, the provisional stent technique may have not been used uniformly across the studies, and that is also a limitation when you try to compare these outcomes of different trials. And finally, the concept of POT, of proximal optimization technique, was introduced around 10 years ago, so it was not performed in the large studies that were performed before this day. Nevertheless, we can conclude that in this network meta-analysis of bifurcation techniques, DK crush was associated with reduced MACE, and it was driven mainly by lower rates of repeat revascularization. There were no significant difference between techniques in cardiac death, MI, or stent thrombosis, and a clinical benefit of 2 stent techniques was observed over 1 stent techniques in bifurcation lesions with side branch length more than 10 millimeters. Thank you very much for your attention.
Good afternoon. Thank you for the invitation. The critical appraisal of the meta-analysis has been previously published in an editorial comment of the JAV cardiovascular intervention. I will try to summarize it in 3 minutes. In all consensus document, provisional stenting or simple approach has been normally considered the preferred technique for the percutaneous treatment of bifurcation lesions. However, during the 2017 TCT, a presentation simultaneously published in JAC appeared to challenge and completely changed this seminal belief. The scientific reaction can be seen in this slide, and the consensus document since the presentation of the DK crash recommend provisional stenting in most of the bifurcation treatment. The European guideline recommend provisional stenting in A class A level for provisional, and in contrast for DK crash they recommend use in A2B with a level of evidence B. So still a stronger recommendation for provisional stenting after the publication. Why DK crash was not generally adopted as the standard strategy for the treatment of true bifurcation lesion? Possible reasons are summarized here. DK crash is a complex technique. Most of the supporting evidence for DK crash originates from a single group of expert operators, and the patients assigned to provisional stenting in this study showed remarkable poor result, which is not consistent with the general experience of many other groups. So the paper of the Georgia, the meta-analysis, represents a timely attempt to clarify these questions. The main conclusion of the paper are that the superiority of the DK crash that was associated with a lower rate of repeat revascularization. And also the clinical benefit of two-stent technique was observed mainly in patients with bifurcation lesion and side branch lesion longer than 10 millimeters. So it seems to be that this advantage over provisional stenting is in these complex bifurcation lesions. My comments to the paper are that in 6 of the 7 studies that including DK crash procedure in this present meta-analysis were led by doctors from the same institution. More than 95% of the patients assigned to DK crash treatment were treated by the same group of expert operators. This may constitute a limitation. And also another important point is that poor results obtained in patients assigned to provisional stenting in these randomized studies seems to be in contradiction with another published series. Reason for poor result obtained in patients assigned or treated by provisional stenting seems to be due to the inclusion of complex bifurcation lesions. So the key point is to identify this type of unfavorable bifurcation lesion. We can use defined criteria, that is a complex score, or we can use a single rule proposed in this meta-analysis, that is a lesion, bifurcation lesion with a lesion length longer than 10 millimeters. My last slide, I think that the clinical implication from this study, bifurcation lesion with long side branch lesion, patients are candidate to an upfront two-stent technique, mainly the DK crash, and non-complex lesion based in these same criteria are candidate probably to provisional stenting. We modified slightly the Medina classification, adding a letter at the end that seems to be useful in the classification of the type of treatment that may receive this patient. Thank you for your attention.
Dear Chairman, thanks for your invitation. The topic of my presentation is the Definition 2 trial. This is my disclosure. So far, there are 4 major randomized clinical trials comparing provisional stenting technique with different kinds of two-stent technique. Of them, Cactus, BBC1, and DK Quash 2 study compared provisional stenting technique with classic quash, all kinds of two-stent technique, or DK quash technique. At 6 months to 1 year follow-up, there was no significant difference in MACE between 2 groups. But in our DK quash 2 study, we provided the significant reduction of tight lesion revascularization (TLR) by DK quash. For these 3 studies, both left main and non-left main bifurcation lesions were included. However, in DK quash 5 study, which compared DK quash with provisional stenting technique, only for distal left main Medina 111 and 011, 2 kinds of true coronary bifurcation lesion. At 1 year follow-up, the primary endpoint, tight lesion failure, was reduced very significantly by DK quash technique. From the table you can see, in Cactus and the BBC1 study, patients with MI CTO lesion or distal left main bifurcated lesion were excluded from these two studies. However, in our DK-Quashi-2 and DK-Quashi-5 study, patients with acute myocardial infarction, CTO, and left main distal bifurcated lesion were also included in these two studies. On the other hand, the side-branching lesion length was only 5 mm from CATAS study, which was not reported from BBC1. And the side-branching lesion length was around 15.1 mm in our DK-Quashi-2 and 16.4 mm in our DK-Quashi-5 study. Also, there was significant difference in terms of the main vessel lesion length between CATAS study and the DK-Quashi-2 or DK-Quashi-5 study. However, the question is that even DK-Quashi-2 study looks the lesion complexity was to be enhanced, but similar to CATAS and the BBC1 study, there was no significant difference too in terms of the maze between provisional and the DK. On the other hand, in our DK-Quashi-5 study, DK-Quashi was confirmed to be superior to provisional studying technique. So from this basic comparison of 4 different clinical trials, so probably lesion location, for example, left main was a non-left main bifurcated lesion. Other angiographic variables as well as clinical variables contributed to the occurrence of clinical events. So far there was no any universal definition criteria to separate simple from complex bifurcated lesion. For this, in 2015 we studied to establish our new criteria from study arm with 1,550 patients with all kinds of bifurcated lesion. After that, the new criteria were testified in another validation group with 3,660 patients with all bifurcated lesion. Finally, we got for Medina 111 and 011 2 kinds of bifurcated lesion with side branch diameter minimal 2.5 mm. We created 2 major criteria, either for distal left main or non-left main bifurcated lesion. Also, we provided 6 minor criteria for distal left main bifurcated lesion, side branch lesion length minimal 10 mm and side branch diameter stenosis minimal 70% was the major criteria. So 1 major criteria plus any 2 minor criteria, lesion could be defined as complex bifurcated lesions. So this is the arms of the definition 2 trial to compare the treatment effect between provisional and two-step strategies in patients with real complex coronary bifurcated lesion defined by definition criteria. These are inclusion and exclusion criteria. Particularly, patients with acute myocardial infarction older than 24 hours were also included in the study. Only Medina 111 and 011 two true coronary bifurcated lesions were studied. The assumption of the study was that the 1-year TF rate was around 14% after provisional and 7% after systematic two-step strategy. The primary endpoint was a target lesion failure, TLF. Finally, a total of 660 patients was required. This is study flowchart to show the randomization of 660 patients into provisional and two-step group. This study was conducted at 49 international centers. So the safety endpoint was stent thrombosis at 12 months follow-up. Angiographic follow-up was scheduled at 13 months, but it was optional. So table show no significant difference in terms of the clinical characteristics between 2 groups. However, patient with acute myocardial infarction older than 24 hours was reported in 22% in both groups. Regarding lesion characteristics, almost 28% of bifurcated lesion localized as a distal left main bifurcated lesion. Most could be classified by Medina 111 true coronary bifurcated lesions. Most of the procedures were performed through radial approach because of the very severely diseased side branch. So in the provisional group, side branch pretreatment was required in 46% of the patient. In the two-step group, DK-Quash technique was most popularly used in 77.8% of the patient compared to 17.9% of Q-long stent technique. In the provisional group, the crossover rate from provisional with 1 to provisional with 2 stent was 22.5%, mostly used with the TAP technique. At 1 year follow-up, the Kaplan-Meier survival curve showed very early separation between two groups, majorly because of the high rate of tidal vessel myocardial infarction in the provisional group compared to 2 stent group. After 6 to 7 months follow-up, so the increase of TAR induced further separation of two codes. Finally, at 1 year follow-up, the TF rate primary endpoint was 11.4% in the provisional group, significantly different to 6.1% in the 2 stent group. However, there was no significant difference in terms of the secondary endpoint, including all-cause death, cardiac death, definite stent thrombosis between two groups. So finally, in conclusion, systematic 2 stent has less rate 1 year TLF for patients with definition criteria defined complex coronary bifurcation lesions, compared to provisional approach, mainly driven by the reductions of tidal vessel myocardial infarction and clinically driven TLR. However, no significant difference in terms of the stent thrombosis between two groups. Because DK quashi was most popularly used in the 2 stent group, our finding may suggest the benefit of DK quashi for complex coronary bifurcation lesion defined by definition criteria. Finally, the underlying mechanisms for the increased target vessel myocardial infarction after provisional stenting technique are still unclear, and further study is warranted. Thanks for your attention.
So thank you, Dr. Chen, for your kind presentation. I think that you and your group should be really congratulated for such a big trial. You focused on complex Medina 111 or 011 lesions with many other features which are really markers of complexity. You randomized more than 600 patients to provisional and to stent, and you've been able to show us a very good result with 2 stents, and you published them inside the European Heart Journal. So really a great job. So trying to incorporate in our practice what you find, I think that it makes sense trying to assess better who are the patients who have been randomized in the trial. And according to the criteria, there was the possibility that the proximal main vessel was not significant disease. However, systematic involvement of both branches was present, and relevant side branches in terms of size were randomized. This is really important, and I think that, however, this is not enough. So we should know more about the characteristics of the patients and the lesion treated in this important trial. To do this, I had to scroll up inside the paper, going to the supplementary material. And if you click on supplementary material, you are able to find the fact that, according to QCA, the lesion length in the main vessel was very long, but also in the side branch there was long disease, since side branch mean lesion length was around 20 millimeters. This is a very, I think, limited subgroup of patients that are treated routinely into the cath labs in the vast majority of the centers in the world. Can we treat this complex lesion with provisional? Well, the Medina 111 lesions might be treated with the provisional in the case the disease inside the side branch is accepted and the tightest lesion is at the ostium. We may have fantastic result with the provisional, with POT, kissing, RIPOT, and this is due to the fact that these manipulations are able to change the shape of our last generation drug-eluting stents. However, if we are in a condition where we have, for example, no proximal disease, but such a long disease inside an important diagonal, to have a fantastic result like that, you cannot be surprised about the fact that you need to implant a second stent during the course of your provisional. All the manipulation you do, like kissing pot, may facilitate you in having this result. And in this particular condition, this has been done according to T-TAP, which is a very reasonable way. So, according to the EBC, provisional is a philosophy that starts with a stent implanted into the main vessel and allows you to go on with further manipulation up to the implantation of a second stent according to T-TAP and Colett. And the operators should take care about the selection of the aggressivity of their intervention according to this. So, coming back to the provisional that has been practiced into the definition to trial and that fared worse than systematic double stenting, can we have more details? Well, according to the protocol, if you see the study procedures recommended, you will find that not to treat side branch at all was recommended according to the study protocol. So this is a very strong attitude, probably not what is recommended by the European Bifurcation Club. Then if you look at the acute results by QCA inside the side branch, you will find that very poor results in the side branch often have been accepted, and the result was highly statistically significantly worse than two stents. Moving forward, when you look at how the provisional flow was followed, you will be surprised to find that decay crash was used in around 20% of provisional arm patients treated with two stents. So this is something that is outside the rules of provisional, and in my mind just testifies the fact that some operators in the trial were probably more friendly user of decay crash than on advanced provisional. That is what is really needed if you want to treat effectively this diffuse and complex disease. And coming back to the BC recommendation in the field, I think that since 2018, it has been clearly stated the fact that when there is the presence of extensive atherosclerosis involvement in both main branch and important side branch, it is very important that we avoid to have occlusion of side branches, and we should be open to implant two stents. Doing this, we may have the possibility to select many techniques. Decay crash is for sure effective, but we have also other alternatives that can be considered according to the operator experience. Thank you for your attention.
So, Goran, it's time for discussion.
Yes. I think anyone who wishes to comment on these studies, to state the current status after these publications, should we modify something or we keep it as it is?
I have one remark about the IVOS, in the presentation of Maciej about the IVOS study. It's if I remember well, meta-analysis. So saying again that we have advantage and probably on mortality advantage to use IVOS for left-hand stenting. But still, I'm very surprised to see that after years and years and years, we don't have a big randomized trial telling that, because I think, at least in my country, to obtain a reimbursement of the IVOS device, we probably will need a randomized trial using IVOS.
Anyone else?
I just want to tell regarding the use of FFR initially, just to select which bifurcation lesion should be treated. Because we have now, and we submitted for publication an article including more than 170 patients, which demonstrates that around half of the patients, even less than 50% from all bifurcations, are practically functionally insignificant. So if we do not adopt this selection exam before bifurcation, we will still include in trials bifurcations that with stents and without stents, the outcome will be the same. I mean, if we include, let's say, 50% of our bifurcations are not functionally significant, how we can talk about outcomes and so on?
Okay,
I agree with you.
Yeah, thank you very much. But let's first focus on three presentations that we had listened before. So we tried to analyze data which are already published in the news session. I see that George Dangas has unmuted himself. George?
Yeah, hi. These are great presentations. And first of all, the IVOS is always a little bit of a puzzle. Even from the beginning, even I remember, I think we must have had some kind of a database analysis 15 years ago. We found that indeed it had a lot to do with the early events, but not really thrombosis that much. So it's been a puzzle that this kind of comes as a recurrent theme. I wonder if just the IVOS is used in the greater plaque burden, and there is some kind of CKMB release from the side branches, and there is some kind of this interaction. I think we need to decipher that in a study. The other comment I want to make is that we see a lot of debate around the meta-analysis and the different techniques. What I haven't seen, and I actually uploaded in the chat a little bit for everyone to comment, is that we don't see exactly what the TLR benefit is from. Is it just from a focal by side branch exclusively, or maybe some interesting restenosis popping up in the main vessel? I wonder if that needs to become a little bit more of a routine reporting than just a generalized TLR. In order to be more specific where this occurs, there may be more worse or more valuable lessons from that.
Thank you, George. Anyone else wishes to comment? Please unmute yourself because I don't see all the people. Maybe Prof. Serruys wants to give his comments.
Yeah, my video is disabled, so you hear my voice, but
Yes.
you cannot see me
Yes,
probably, but that's the host who did it, not myself. Yeah, the general comment is that, we have let me see if there are, yeah. The point is that in trials, what you have generally is what we call an average treatment effect. The clinician is looking at this Kaplan-Meier curve diverging, and then they conclude one is better than the other. It's a kind of binary response. It's a kind of summary response, is what we call average treatment effect. What I really appreciate during this presentation is the fact that when you start to introduce granularity, that was the analysis of Burzotta, that was the analysis of Colett, then you start to see the individualized aspect of the patient, the individualized aspect of the bifurcation. And you start to realize that 10 or 20 millimeters suddenly make the things different. I think that's my first comment. The second, if you look at the decay crush, I mean, obviously there was a drop for the provisional, which must be related to the peri-procedural MI. And you know how difficult these days is the peri-procedural MI. There have been these two papers by Greg Stone and myself really questioning our approach of the peri-procedural MI. And finally, I think that there is a basic dilemma, which has been also very well illustrated in the discussion, is that, you know, when you have something so much unblinded as two stand versus one stand, one country and one continent versus the others, it has been said many times that in China, they were proficient, long experience, discipline to do the DK crush, and then they were maybe not naturally proficient in the provisional. So you feel the impression that the only way to resolve that would have to be a randomized between multiple countries with people who are proficient with the provisional and proficient with the DK crush. Then you get probably the correct approach, but that's almost impossible. You know, it's a little bit like when we introduced the stent, we were biased for the stent, and we had some bias against the balloon angioplasty. That problem will stay. But certainly individualized, pick up what makes the difference is so important, yeah.
My comment, if I can enter, Professor Serruys, I think that it is perfectly in line with that, because we see repeatedly that in trials in bifurcations, TLR is the main determinant of outcome. Okay, and TLR may be driven by different aspects. One of these is the systematic search for ischemia. And it is done in many countries, but we know that ischemia now, stable ischemia, is something which is less important probably than symptomatic ischemia. And if you start treating well the main vessel and leave a side branch, you may have inducible ischemia. We documented the fact that you may have this ergometric test which is positive due to a side branch stenosis. So if you look at the DK crash trial we discussed, the definition, you will find that when you look at the reason for re-angiography during the year, there were more suspected chest pain into the two-stent group, significantly more, and more clinically indicated ischemia into the provisional group. And both of these may driven the TLR, but we do not know if it is really appropriate. So this is, I think that it is an important argument to understand what is the outcome which is of interest in trials. Most of the technical aspects and refinements have been focused on reducing peri-procedural complication. It makes sense. Now, if we look at the long-term outcome, probably very long-term outcome is important if we want to have measured adverse events.
Thank you, Francesco. We need to continue.
Okay, thank you.
Dear colleague, it's a pleasure for me. I'm thanking our host, our president, Goran Stankovic, for the invitation. And I'm going to show you all the works that's behind our EBC white paper on the antithrombotic therapy after PCI of bifurcation lesion. I have no conflict of interest to disclose. And I have to underline something that's very well known to you, meaning the swinging pendulum of length of depth duration that this is the very newly released network meta-analysis where extended depth duration, and you can see here beyond 12 months is associated with a significant reduction of myocardial infarction, but on the same time, it significantly increased the risk of major bleedings. And this is particularly true when we speak about bifurcation lesions. In the definition to study, they try to have a standardization of the complexity of bifurcation apart from the Medina true. You can see here that among the major criteria and the minor criteria, you can find again a conflict between the lesions in the large vessels like left main and at the same time lesions in the small vessels, meaning that not always the extent of thrombotic risk goes in the same direction to the extent of the ischemic risk, because a large ischemic area can be less thrombogenic than a small ischemic area, like in small obtuse marginal and large left main. Which patient will be eligible for extended DAPT duration? And then therefore there is no consensus for neither the appropriate PCI strategy nor the optimal regimen and duration of that antithrombotic treatment that should be aiming to decrease the risk of ischemic and bleeding complication in PCI coronary bifurcation. Most of the currently available evidence about antithrombotic therapy in bifurcation PCI is not derived from major dedicated studies, and that's why we have not focused the guideline approach. Therefore, that's why the ABC promoted a state-of-the-art paper on antithrombotic therapy after bifurcation PCI. And key opinion leaders from Europe, America, and Asia were identified on the basis of expertise in either basic, translational, and clinical science, focusing in the field of antiplatelet therapy and interventional cardiology. All invited the experts agrees to partake in the development. This was a tough work, and I thank all of them, and endorsed the advice that were provided. There was anyway no financial support and no industry involvement in the preparation of this review, and the agreement from the various scenarios we reached by discussion of the available evidence. And I'm very honored to share with all these distinguished colleagues and friends in order to have the production that was very fast. I thank your intervention for the sensibility of having a big support in their editorial staff. The paper was swiftly promoted. And for the paper itself, for the core part of the paper, we should start from the table that you will find on the paper, where are summarized the 8 studies that were focused on the DAPT duration. And starting from the Justino meta-analysis that were from where there were the famous now Justino criteria, we can see that long-term double antiplatelet therapy reduce the risk of MIS in the and this reduction is directly proportional to the complexity of the patient. If on one side is directly proportional to the complexity of the patient, on the other side, it increases the risk of bleeding, and that's most evident among patients at higher bleeding risk, either identified with DAPT score or with precise DAPT score, with a lower DAPT score. So in other papers like our registry, there was also a message for strict following the guidelines, meaning if we follow guidelines, we are more safely giving antiplatelet therapy, and also a word for a planned procedural strategy, because we can see a bailout stenting beyond planning was associated with increased risk of thrombosis. And then we go towards a tailored approach in which clinical presentation, stenting strategy, intravascular imaging, and bleeding risk were major determinants of what we build up. And we try to build up a useful message for all researchers in modifying the usual algorithm PCI. PCI now by guidelines is followed by DAPT duration according to clinical presentation, 6 months in stable coronary artery disease, 12 months in acute coronary syndromes. this can be modulated in patients according to bleeding risk. The DAP duration can be out to 3 months after stable coronary artery disease to 6 months after acute coronary syndromes in patients that have bleeding risk. But when we go in the setting of PCI of coronary bifurcation, we see that the complexity of procedures takes part in this strategy decision algorithm decision making. So in single stenting, double stenting, of bailout stenting, we have different DAP durations suggested by our panel of experts. And we can see that bailout is undoubtedly a situation in which 12 months is mostly always recommended, while for double stenting, a shorter duration in high bleeding risk can be recommended. If patients are the procedures are closely monitored and optimized by intravascular imaging, either IVUS or optical coherence tomography, then we can afford also a further reduction of DAP duration with good safety margins. So we are very happy to declare that this white paper will be released next January 2021. It has been already diffused in the preliminary part, also on the media, social medias, and we will all be delighted if you will read it and share your comments on Twitter, Facebook, or also by mail. Thank you very much for your attention.
So thank you, Marco, and I will try to be on my 3 minutes appraisal and be back on time, being the only woman present in the panel. I think that, first of all, many compliments, congratulations to Marco to have led this big effort. I know how much effort you have to take to do a consensus document, and especially when you are putting together experts from different countries with different practice and local condition. And clearly this document is addressing what is nowadays an unsolved issue. I mean, it is still unsolved despite some randomized clinical trial on the topic, which is the optimal dual antiplatelet therapy after DS implantation. And more than ever, it is unsolved what you have to do when you are dealing with a complex bifurcation lesion. I think that any of us as operator and as clinicians have several calls from our surgery colleagues to what to do in case they do have to go to surgery, what to do to our patient. By chance, I just had one of these calls yesterday, what to do in a patient that I treat with decade crash and now has to undergo surgery, what to do, what you have to stop, are you safe to stop, and which are the plans. And clearly we do not have an answer. So I think this expert consensus is trying to answer to an unsolved issue and a big clinical need. The ABC white paper, that is a kind of expert consensus document, is looking to the publication so far, and it's a mixture of patient level analysis as the one by Gennaro that I took part to, or randomized trials, or it's a mixture of what is published in the literature. And starting from these and trying to identify which could have been the authors coming from different parts of the world, they try to build up an algorithm. And according to the algorithm, they took into consideration 4 variables. First, clinical presentation, that we know it's very important, stable versus acute coronary syndrome. Second, they were taking into account the presence of imaging or not, with all the bias of this, because as we know, it depends what do you mean to do an imaging, and I absolutely agree with what George was saying before. What is imaging? Are you guiding your procedure? Which criteria are you applying? Then taking into account PCI strategy, clearly it makes a difference if it's one stent or dual stent and then bleeding risk. So they came up with an algorithm proposing different up duration. But I mean, that's very interesting. I think you needed this, but it should be a starting point. But because clearly you need to validate this model. And to validate if really taking this algorithm that is taken from studies but not being validated, you can use in everyday practice. So are we really sure that this is the algorithm that we can apply to our patient, and what to do next? What to do next clearly is to validate something like this, and maybe this can be a topic for a future study from European Bifurcation Club registry. So let's try to apply the algorithm and really let's see if the algorithm is leading to less events without not applying this algorithm. So again, I think it's important, but it should be taken into account the limitation, because this is just taking what are the publications so far and building up an algorithm with so many variables where actually you did not look to the interplay among the different clinical variables. This should be rather a starting point for a study or a registry or something that really will guide our procedure and make us feel safe to stop the antiplatelet in some of these categories. Thanks.
Yes, thank you, Alaide. I'd like to thank Professor Stankovic and members of the EBC committee for inviting me to present our ABC classification of left mainstem disease. My name is Mamas. I'm Professor of Cardiology based at Kiel University in the United Kingdom, and I'm also presenting on behalf of Professor Joseph Ludwig from Germany. So the Medina classification represents the current gold standard for classifications of bifurcations, both left main and non-left main. And it consists of three numbers, characterized by the presence of disease in the main branch proximal vessel, the first number, the main branch distal vessel, the second number, and the side branch, the third number. So you can get 7 different types in the left main, depending on the presence of disease in the proximal, distal, and side branch. However, Medina has a number of limitations, particularly in the left mainstem disease. So first and foremost, it does not provide information around sizing of the vessels, which is crucial in defining strategy. As you can see in the 2 examples below that may have very similar Medina classifications, the top left figure shows a very dominant circumflex, whereas on the right it shows a very large dominant LAD. And the treatment strategy would be very different in these 2 examples. Medina also does not take into account dominance of the LAD and circumflex. So for example, a 110 lesion as defined by Medina would suggest disease in the proximal main vessel, in the distal main vessel with no disease in the side branch. But of course, it very much depends on what is considered to be the main vessel. So generally, we would consider the LAD to be the main vessel. But if you have a very large dominant circumflex and a very small non-dominant LAD, the circumflex becomes the main vessel. And so immediately you can see the confusion. And thirdly, the third problem is around trifurcations. So from the Excel randomized control trial, we know that 10% of distal bifurcations are in fact trifurcations, and around 1% are quadrifurcations. And therefore, describing trifurcations using Medina is challenging, and describing quadrifurcations is almost impossible. That is why Dr. Joseph Ludwig and myself have developed the ABC classification of coronary artery disease for left main. So each vessel is named with a certain letter. So the left main is termed A, the LAD B, the circumflex C, and intermediate D. Sizing of the vessel is characterized by either a capital letter if the size is greater than 3.5 millimeters, or a small letter if the size is less than 3.5 millimeters. And finally, the letter is present if the disease is significant, i.e. there's a 70% reduction in lumen diameter, or positive FFR or CT FFR, or based on anatomical considerations such as IVUS and OCT. So in the top left example, it's capital A, capital B, capital C, because each branch is greater than 3.5 millimeters and there is significant disease in the left main, LAD and left circumflex. In the middle example, it's capital A, small b, capital C, because the left main is significant and it's greater than 3.5, therefore it's a capital A. The LAD is significant, but it's smaller than 3.5, therefore it's a small b, and the circumflex is significant, therefore it is a capital C. And on the far right, it's capital B, capital C, because the disease in the left main is not significant. The disease in the LAD is significant, and the vessel is greater than 3.5 millimeters, therefore it's capital B, and small c in the left circumflex. And these are some examples. So in this example, you have significant disease in the left main, so that's capital A, a small LAD, small b, and a capital C because the circumflex is greater than 3.5 millimeters. In this trifurcation, you have significant disease in the left main, so that's capital A, significant disease in a large LAD, so that's capital B, and both the circumflex and the intermediate are smaller than 3.5, so they become small c, small d. In this example, IVUS did not show the left main or the LAD to be significant, and therefore the only significant lesion here is in the circumflex, and this is a large vessel, greater than 3.5 millimeters, therefore it is capital C. And this is another example, capital A, small b, small c. So in summary, the ABC classification provides advantages over Medina for left main stem disease in that it provides sizing information, removes confusion regarding the side branch in case of dominant left circumflex and small LAD. It enables classification of trifurcations and quadrifications, and it's easy to remember. I thank you.
Hello, friends. Hello, mamas. Welcome in the Bifurcation Club with your proposition of a new classification for left main bifurcations in association with Joseph Ludwig, who is one of the early members of the club. Many classifications of bifurcation lesions have been proposed in the past. Here are some of them. About the Lefebvre classification, it was said in France that only Thierry was able to remember the classification. In the first EBC meeting in Bordeaux, October 2005, Alfonso Medina proposed a new classification of bifurcation lesions, just published in Journal of Cardiology from Spain. Here it is, 3 segments for a bifurcation. When it's 1, it's more than 50% stenosis, 0, less than 50% stenosis, and you have 7 situations described. After adoption of Medina classification as the official classification of Bifurcation Club, we received some proposition to change for others, more simplified, like this Movare classification, not so simple in its basic version, and really complex when you consider the calcium and the left main, as you can see. More serious and dedicated to left main bifurcation is the ABC classification proposed by Mamas and Joseph Ludwig. For them, what are the Medina limitations for left main bifurcations? They said circumflex LAD dominance, left main trifurcation, and segment size. This is the glossary of European Bifurcation Club, was published in 2008 after 1 year of discussion. In this paper, we show how to name bifurcation lesions. You can see at the top left, TAQI Colett CX1, MG1 CX2, and this is a 100 lesion. You can do that for distal lesions, and you can do that also for trifurcation. Left main, LAD1, ramus, CX1, 1, 1, 0, 1 lesions, perfectly defined. So you can choose choose the anatomical circumflex dominance or its diameter to define it as a main distal vessel, or you can take into account a previous MI in the territory of LAD, and we just have to name your bifurcation to do it. What about segment sizes? You know that the sizes are following the More's law. You know also that the diameter of vessels are depending on the status of the patient, and segment diameters are continuous variables. So the choices you are doing are arbitrary. I suppose you were influenced by technical aspects, like in this maximum expansion stent chart by Fuin. What is our Medina classification? First, it's simple. It's easy to remember. It's a research classification, not yet a recipe book. Can be used for inclusion in randomized trial. It's incomplete, like the EBC classification, but it can be filled and completed using classification from QCA, IVUS, Society, FFR, and so on. So if you ask an old international cardiologist with a limited memory, which classification he preferred, I would say Medina classification, of course. Thank you.
Hello from New York.
Hi.
I'm very happy to be able to present to you the SKY Bifurcation Club, a global initiative of the Society of Cardiovascular Angiography and Intervention in Ischemic Heart Disease Committee and of the Society in its entirety. And let me take a moment to congratulate the European Bifurcation Club for its really great course over many, many years of debating, generating data, generating interest all over the world in coronary bifurcation, bifurcation stenting, and also the different approaches. We're going to miss it this year due to the pandemic in person, but hopefully we're going to repeat these great experiences in the years to come. After a couple of years of deliberations, under the presidency of Shami Mahmood last year, everything was settled and decided to move forward. And finally, this summer, under the presidency of Dr. Cindy Grimes, well known to all of you, it was finally signed and sealed by the executive board in August. And here we are in October, announcing in person to you its formation and our mission. Our mission statement reads to promote excellence in coronary artery bifurcation interventions worldwide through innovation, multidisciplinary research, technological advances, education, and production of consensus documents and guidelines. The core values and objectives are patient-centered approach and inclusiveness and diversity in the disciplinary collaboration, innovation, and science. The initial working group has a broad representation, and you can see in the map how many states are represented right away, great distribution with a very diverse background and clinical practices as well as academic interests among our initial members. And again, we encourage participation for many, many others as long as all they want to be members of the society. On top of that, we're very much aligned with everything else that happens around the world. In North and South America, you can see the Canadian Society and the Canadian Bifurcation Club, as well as the Latin American Bifurcation Club. And obviously, you can see the activity of our all global partners, inclusive of your very own European Bifurcation Club, as well as all the activities in China, Dr. Chen and others. And all of us are already have a seats working around the table and talking to each other and creating consensus, and of course creating also feeding many more debates that we all like. In brief, SKY Bifurcation Club is a natural society-driven initiative to harmonize, discuss, and debate the various issues and interests in bifurcation interventional approaches around the world. Thank you very much for your attention, and many greetings to EBC once again.
Mr. Chairman, thank you for the invitation to EBC 2020. I'm Tanveer from Atlanta, Georgia, in the United States. I'm here to introduce the American Bifurcation Club that was created a few months ago. The American Bifurcation Club was created with the support of C3 and the Interventional Academy. Many of you know Rajiv, who has over the years invited the European Bifurcation Club to the annual C3 meetings where EBC has had its own dedicated sessions. For several years, following the encouragement by Yves Louvard, Thierry Lefebvre, Jan Lassen, Goran Stankovic, and Shao-Liang Chen, I thought about the creation of a bifurcation club in the United States. I'm pleased that with the support of C3 and the Interventional Academy, that has now been accomplished. The American Bifurcation Club is an independent organization and it's an open forum organization. I'm delighted to have highly skilled interventionalists who are high volume operators, passionate about coronary bifurcation intervention, involved in clinical trials, in techniques, and research in the science of bifurcation. Currently, I serve as the president of the American Bifurcation Club, and Raj Dave is the CEO of C3 and the Interventional Academy. I'm pleased to have with us Richard Schlafmitz from St. Francis, New York, Azim Latib, whom you know very well, from Milan, who's currently at Montefiore, Kevin Crouse from Harvard's Brigham and Women's Hospital, Matthew Price from Scripps Clinic San Diego, Vlad Dzavik from the University of Toronto, Arasi Moran from Medical University of South Carolina, Don Abbott from Brown in Rhode Island, Bar Basir from Henry Ford in Detroit, Pervez Miraj from Northville in New York, and Gautam Kumar from Emory University and the VM Medical Center in Atlanta. Our mission statement is really about cases to teach and learn from the coronary bifurcation and left main cases presented in monthly webinars titled the ABC Bifurcation Hour. It's open to all interventionists to submit cases that we selected for presentation and discussion by the founding members. We will build consensus on the North American approach to bifurcation lesions and develop research protocols for trials and registries in bifurcation PCI. On Saturday, October 10, 2020, we had an introductory webinar. 3 cases were discussed. There were 103 participants on Zoom and 1,000 participated in Facebook live stream. We were delighted with such a good response. We also on social media on Facebook, Twitter, and LinkedIn with over 400 followers on Twitter. Mr. Chairman, thank you very much for the unique honor of recognizing the American Bifurcation Club. The founding members are absolutely delighted and pleased with the honor that you've bestowed us. We thank you for this invitation, and we hope to meet you in the future for our future common endeavor in the treatment of coronary bifurcation lesion. Thank you very much.
Good morning. My name is Carlos Uribe. I'm from Colombia, South America. And on behalf of the Latin Bifurcation Club, it is truly an honor to be here. I would like to thank all of the European Bifurcation Club directors for having invited us. It's truly an honor to be here presenting the Latin Bifurcation Club. So as you might know, PCI bifurcation is definitely have the worst outcome when compared with simple lesion, and this is because these are very different, wide spectrum of lesions, of coronary lesions. There is a lot of ways to treat it and to tackle it. There is no uniform way, and there is a lack of data on how to treat them. So even though there is a published worldwide guidelines, especially in Europe, about bifurcation treatment, in Latin America, there is no uniform thinking on what to do with a bifurcation. So this lack of familiarity and this lack of awareness with current bifurcation techniques and the proper way how to treat them prompt us to do a LATAM bifurcation club in order to have and to recommend guidelines and to give lectures about it. So there is definitely a regional and in between countries differences. There is even this is more important in non-academic centers, and we have seen that often outdated techniques are employed for treating simple bifurcation lesions. So in Latin America, this reality is even more important. than in other regions because of economic constraint. So we definitely need to adapt a consensus or guidelines for the Latin American realities, and to take all of these proved and tested concepts published based on data and based on evidence, and adapt those to the Latin American realities. That is one of our challenges. So with that in mind, the objectives of the LATAM Bifurcation Club is first to collaborate and to set a platform for research and to discuss how to treat bifurcations in our region. Second, to set common points on how to treat bifurcations. And most importantly, to adapt all of these ideas to Latin American realities. Also to organize and create workshops and meetings in LATAM to spread those concepts for the proper treatment of bifurcations and for the proper care of our patients. Also, we are look forward to have registries and research on how to treat bifurcation in Latin America. And lastly, to generate ideas and research and to do a collaboration with the other bifurcation clubs worldwide. So we have a steering committee who will advise us on how to meet all of these objectives that I previously mentioned to you, and also to help us in writing this consensus and to set down these guidelines and to adapt us to Latin America. So this is my last slide, which show you the organization chart of the LATAM Bifurcation Club. So thank you very much. With much further ado, this is what I have to show you today. Thank you very much.
Ladies and gentlemen, dear Chairman, thank you for the kind invitation to present at the EBC 2020. I'm going to introduce you in the next 5 minutes to the Bifur-Shock trial. As we all know, bifurcation lesions, even when moderate or severe calcified, are always a challenging situation in interventional cardiology. If you look at the published data, even when calcium modification tools such as rotational atherectomy is used, the results demonstrated no superiority in comparison to the standard procedure. So there are obviously some limitations coming along with the rotational atherectomy. Some of them are inability to navigate through a tortuous anatomy and severe angled side branches. And we know with rotational atherectomy, multiple wires down while modifying calcium is not possible. And finally, circumferential calcium modification without wire bias is not possible, leaving unmodified areas behind. The question is, can we do better? And for that, intravascular lithotripsy was introduced as calcium modifying tool, coming with a balloon catheter and a generator. The generator produces energy which are applied by the emitters in the balloon catheter. And a small electrical discharge at the emitters vaporizes the fluid within the balloon to create a rapidly expanding bubble that generates the sonic pressure waves and then collapses within a few microseconds. When the waves impact the calcium at nearly 50 atmosphere, they create a series of microfractures, and this makes the vessel more compliant. This is an OCT image after lithotripsy showing the nice microfractures of the calcium here in the middle panel. From early studies, we know that the IVL is most effective in long and in death calcified lesions. The safety and the efficacy of the system has been proved in the CAT1 and 2 trial, and moreover, we looked a little bit in more detail to the bifurcation subgroup out of these 2 trials, and in this preliminary analysis, safety and efficacy was confirmed. Therefore, we initiated the Bifur-Shock trial, which is a randomized controlled open-label multi-center trial in 300 patients with moderate to severe calcified bifurcation lesions intended to treat with a 2-stent strategy. After intravascular imaging, the patients are randomized either to standard procedure with NC balloons or to lithotripsy before stent implantation. Key inclusion criteria are clinically relevant calcified coronary bifurcation stenosis according to ACC/HA class 1, 2, 3, Medina class 111 or 110 or 011 as estimated by angiography. Furthermore, there have to be relevant calcification defined as angiographically moderate or severe according to HA definitions. Main exclusion criteria are cardiogenic shock or lesions of the vascular systems or neuropathies that prevent percutaneous transluminal coronary angioplasty or the use of a stent. The primary endpoint is the minimal stent area measured in the side branch. Secondary endpoints are furthermore clinical parameters also evaluated after 12 months. So therefore, I like to conclude, calcified bifurcation lesions are always challenging. We have some treatment options, however, they are limited, and intravascular lithotripsy might be an alternative to other calcium modification therapies. However, randomized trials just as Bifushock are needed to clarify its efficacy and safety. Thank you very much.
Good afternoon. Thank you very much for inviting me for this great session. It gives me opportunity to remind you about Paul's left main study. I am very grateful to Professor Patrick Serruys and his academic team for preparation of this presentation. Paul's left main study in cooperation with Professor Patrick Serruys as a single-arm prospective multi-center study. We plan to enroll 260 patients presenting less than equal 32 syntax score and more or equal 50% diameter stenosis in the distal left main, either on the basis of standard bifurcation dedicated quantitative coronary angiography or the FINE low-derived QCA. The aim was to demonstrate non-inferiority of this earlier mentioned stent against Xience stent for distal left main disease. The endpoint was patient-oriented composite endpoints defined as a composite of all-cause death, stroke, and myocardial infarction, and any revascularization. Unfortunately, due to the COVID-19 pandemic, we were forced to halt the enrollment to the study, and we decided to use this time for interim analysis, taking account half of the planned patient to be enrolled. Unfortunately, we are not ready with this assessment. Instead of that, I would like to present you some answers for the questions rose at the beginning of the trial. Would the use of single QCA method have impacted the enrollment eligibility rates? Does QCA-based evaluation impact the Medina classification compared to the visual one? Which is the agreement between visual and functional by IFR evaluation of the lesion severity? Here you can appreciate the answer for first question. You can compare real enrollment and potential enrollment based on these two algorithms of bifurcation quantitative assessment. We found that in 113 patients would have been enrolled on the basis of standard QCA only. 101 patients would been enrolled on the basis of FINE-derived QCA only. And overall, the two methods were concordant in 94 out of 120 patients, so it means less than 80%. Here you can appreciate the examples of measurements using this standard dedicated QCA analysis in a different Medina class bifurcations with average values for percent diameter stenosis, MLD, and reference diameter. The same for second system, assuming also Finet law. You can appreciate the higher value for percent diameter stenosis and reference diameter for left main. The second question, comparison between Medina classification according visual assessment and quantitative coronary and geography analysis, we found that these findings suggest comparable rates of Medina classes by using one of the other technique. However, a slight overestimation of the 111 class rate was observed on the basis of the visual estimation. The third question, comparison between visual and functional assessment of bifurcation severity, we found that in 82% cases, the two techniques were concordant with the correlation coefficient 0.45. Very interesting slides showing the relationship between IFR and percent diameter stenosis assessed by dedicated bifurcation QCA. We found moderate negative correlation between IFR and percent diameter stenosis and good predictive value of percent diameter stenosis to identify IFR less than equal 0.889. In conclusion, the use of single QCA method, either the bifurcation dedicated QCA or the Finet law derived QCA, would have reduced the enrollment rate. Medina classes rates are comparable when evaluated by means of visual or QCA-based assessment. Functional investigation of left main distal stenosis by IFR agreed with severity of visual assessment in more than 4/5 of cases. Thank you very much for your attention.
So I hope you can hear me at the moment. I'm going to present some details about the EBC main European Bifurcation Club trial, which I hope will be hotly anticipated when we get to present the actual results. So this trial has been going for some time, as you know, started in 2015, in fact. It's the European Bifurcation Club left main coronary study, and it's a randomized comparison of the provisional versus the systematic stenting strategies for true bifurcation left main coronary lesions. The hypothesis of this study is that left main true coronary bifurcation lesions are best treated with a stepwise provisional stent strategy rather than a planned dual stent strategy. As Jens Lassen wisely says, when you start with one stent, you can always end up with two, but when you start with two stents, you can't end up with one. The primary endpoint at 1 year is death, target lesion revascularization, and MI at 1 year. So the study design is multi-center, prospective, randomized. There's 450 patients in the study, 30 centers and 10 countries. So it's been a very large effort getting this together, and this has been coordinated through CERC. Medtronic provided an unrestricted grant, and the stent used in the study is the Medtronic Onyx. Briefly, the main inclusion criteria were that patients should have a bifurcation distal left main stem stenosis greater than 50%, and they should have ischemic symptoms or a positive non-invasive test or positive FFR or left main stem IVUS area less than 6 square millimeters. Of course, it had to be a true bifurcation type, and the LAD and circumflex both had to be large enough to warrant stenting. The techniques are sometimes misunderstood. The provisional approach is a step-by-step layered technique. It's not a
sort of one stent technique as such. It is a method of gradually increasing the complexity of the procedure until you get the result that you need. In this study, the pot will be mandated and the KISS will be mandated because both branches are important and both have significant disease. On the systematic approach, this will be up to operator choice. There are reasons why people will prefer one technique than another, and the various two-stent techniques are all allowed within the study. We're expecting people to undertake high pressure, as it were, osteal dilatations of the vessel and to do a final KISS plus or minus pot. The recruitment was slower than we might have hoped because it's difficult to recruit these kind of patients in Europe, and so it's taken a good 4 years to have complete recruitment. Congratulations particularly to centres such as the Newcastle Centre Mohamed Egred, Oxford and Fontaine-les-Dijon also recruited very heavily, so a range of recruitment. And so now we come to the results of the study. Actually, sorry, no, my mistake. We can't produce the results at this stage. What we can produce, though, is the demographics. And this is just a teaser, really, because the study is now under analysis. The final patient went in November of last year, so they're at a year of follow-up just coming up. In the final analysis, we have 224 patients in the provisional group, 229 in the systematic. The age of the patients, roughly 70 years old, unsurprisingly 75% male. Perhaps interesting to see the diabetic rates. A quarter of the patients are diabetic, not surprisingly, and a reasonable high-risk patient group in that a quarter have had a previous MI and some have had previous strokes or existing renal failure. So this is just a teaser for the final results, which will be available at PCR 2021 if the abstract is accepted. And I think it will be very interesting to see how these results compare with the previous trials. Thank you.
Thank you very much, Dave. Maybe Yves should give general comments. I'm sorry for this delay, but this is European Bifurcation Club. As soon as you start discussion, you have a variety of opinions, and I suggest that we continue discussion by mail. And Yves, please give your final remarks before we proceed to the second session.
And we had again a discussion about double stanting versus provisional decay coach versus provisional for left main lesions. And the data presented suggests that we may have in the future to perform another randomized trial on very complex patients with definition, for example, of a lesion in the side branch more than 10, 15, or even 20 millimeters. Of course, the longest, the more difficult to perform. And the systematic double stanting, beginning with the main or beginning with the side, will be a fair comparison, as the decay crush, in my opinion, was not, leaving many side branches unstanted. So to perform this kind of trial, we need, as David said, it's not easy, at least in Europe, to recruit such a patients. So I think the opportunity of having multiple clubs in the world now will be good to promote trials that can be global. Why not? And we can work on this possibility. As Alaide said, we also have to validate the work of performed with Marcos de Marinos, the algorithm. Can be also, we need probably big numbers also in this situation. And this is the second reason to work with many clubs you have in the world. Some of them were not presented today. There are really many clubs, like in India, like in Bulgaria, and so on. I was claiming 2 years ago, to have a trial on shockwave. So Holger Neff is proposing, and we are of course very interested to see that. And we wait with a lot of interest the Paul Boss, the result of Paul Boss trial and some sub-studies coming from the Paul Boss trial. And also, of course, EBC men during the PCR 2021. So I thank you very much for participating in this session.
Thanks, Yves.
Thank you.
Welcome to this special EBC bifurcation session sponsored by Terumo. The learning objective of this session is to understand the best treatment option for patients presenting with complex bifurcation lesion, to share a benchtop simulation of bifurcation techniques during the live case, and to learn how to optimize both the strategy and the technique. The case will be performed by José María de la Torre Hernández from Santander. I will describe the case.
To all of you, good morning, Thierry. We have a 65-year-old male patient here. He's ex-smoker. He's the only risk factor, cardiovascular risk factor he has. He's complaining of chest pain, of low exercise level, and even the Rex in the last 1 to 2 weeks. The episodes are lasting for 5 to 10 minutes. Are short, but he was really concerned, and he attended the ER and was admitted a few days ago. In the EKG was evident the presence of mild ST depression in V5, V6. Mild high-sensitivity troponin I elevation was noted. And in the echocardiography, a normal ejection fraction was evident with no segmental wall motion abnormalities. This is the bifurcation, but I can show you other data because I have the angiography done today again. We did the diagnostic the other last week, and you can see in the slide the bifurcation in the CERT that is really the culprit. But we have here the right coronary artery, which is normal. There is no stenosis in any place in the right. And we have here the angio for the circumflex. It's the same as you can see in the steel frame in the slides. You see a severe lesion in proximal CERT, really severe, focal, no calcified. It is involving the proximal part of the bifurcation. Then the side branch is mildly to moderately affected, and the distal main branch is only mildly or not significantly affected. We could say that if we go to the next slide exactly, this is the Medina 101 classification for this bifurcation. And this is the circumflex, as I say, the lesion, and LAD, no lesions. In the slide, you can appreciate the QCA of the lesion. The main branch proximally is 3.7 millimeters, distally is 3.5, then is small tapering, but it's a large vessel. And the side branch is in diameter, reference diameter 2.6. Then, Thierry, this is the bifurcation we have today. It's 101. And what is your idea about the approach?
I think it's a very nice case. I think, of course, there is many options, but in this particular case, I think provisional side branch treatment is a good one. The lesion is very tight in the circ, so I will start with 2 wires for protection of the side branch. Maybe pre-dilate or not, I don't know what is your current approach.
Yes.
It's kind of recent angina, but I think there is many options.
Yes, we agree with Thierry. We are going to approach with a provisional stent, which is the most common approach. And because a very tight lesion, we're going to pre-dilate. We have to use a Uribe balloon, a semi-compliant balloon. Please give me a 3 millimeters, 320. Uribe.
Okay.
We're going to pre-dilate with a 320 to start with. I hope we are going to cross, despite the severity of the lesion, there is no calcium. And we are going to pre-dilate the main branch. We're not going, Thierry, to pre-dilate the side branch because it's very hostile, no calcified, not very severe, normal flow. What do you think?
Yeah, I fully agree. I will not pre-dilate, just protect the branch and decide after stenting the main what we should do in the side. So
yes.
We'll use for stenting Ultimaster Tansai, and you plan to use OFDI at the end of the procedure.
Yes, exactly. That's the idea, to optimize the stenting result by OFDI, balloon wave, And to see we have a good apposition, particularly proximally. We have good expansion and the more critical segment. If we had good coverage, everything. Really, the optimization with the imaging is quite relevant, particularly in bifurcations like this, or leg main, particularly, and other lesions.
So the plan is to use Ultimatum Stansai, which is a very nice stent for treating bifurcation lesion because of the open cell design, uniform scaffolding, and also the good expansion capacity when you have discrepancy between the distal reference and the proximal reference. One important question is the strategy for bifurcation, and we have very nice data from the e-Ultimaster registry showing that proximal optimization technique is a crucial step when treating bifurcation lesion. You can see in this very large registry of more than 4,000 patients that if you do proximal optimization technique, you decrease the risk of TLF and stent thrombosis. Unfortunately, in this international registry, only 1/3 of the patients had proximal optimization technique. So it's very important to insist on that. Using POT is a step which is fundamental when treating bifurcation lesion, whatever the technique.
We're pre-dilating. Really, the Uribe balloon is a very good balloon, a good low profile, good navigation, crossability, and really you have a very smooth transition of these balloons, even through the most tight and severe lesions. We also take advantage of the balloon to make our measurement of the proper stenting, because you can see here, this is the ballooning with the full expansion, the plaque is shoved, and this is the 20 millimeters balloon. Then the stent, as you can see, should be around less than 20 millimeters. Could be 18, for example, or 15 even. We plan to go from healthy to healthy. The distal main branch looks not, geographically not affected, but offshore is going to be in somehow affected. So we have to go across the side branch and to reach, maybe to cover at least 10 millimeters or 8 millimeters off from the distal main branch. Let's see what's the result after predilatation. I'm going to show you, this is the result after predilatation, which is good.
Yeah.
And we're moving fast. We are just going to stent the lesion because the behavior of the balloon was very good. There is no calcium. Then we can go from the 3 predilatation to the 3.5 stenting. I don't like I don't know what you think, Rajiv, but when I don't see calcium, when I see an unstable plaque, I don't predilate with a 1:1. I sometimes go a bit smaller, particularly in unstable lesions, very fatty lesions, in bifurcations, in order to prevent maybe a dissection that is going to make you implant much longer stents. What do you think?
Yeah. Oh yeah, I fully agree with you. And in many cases, I'm not doing predilatation because when the patient is unstable, usually it's a soft plaque. But if I do predilatation, I use a small balloon.
Exactly.
Smaller than the reference. What is interesting after predilatation is that the proximal part of the vessel looks bigger than 3.7. The QCA showed 3.7 and 3.5 for the distal and the proximal and distal reference, but it looks close to 4, in fact.
Yes, it looks larger. Yeah. When you open the artery, you have more flow and more dilatation of the vessel because of the effect of the flow over the endothelium and all this.
To think about the proximal optimization technique and to have enough space proximal to the carina to be able to do proximal optimization technique according to the balloon that you have in your shelf. So what is the shortest balloon that you have in your cath lab? Is it 8, 10?
We have balloons for 8 millimeters.
Okay.
And we can do, we have 8, we have 10, we have 12. That's good to have, as you say, very short balloons for pot in bifurcations, because sometimes the proximal part to pot is very short and you don't want to do a geographical maze to dilate with balloons that are longer than the proximal part of the stent.
Absolutely.
We're going to implant a 3.5 millimeters because we just sized the stent with the distal main branch. The distal main branch is for the sizing. And then for the proximal part of the stent, we will do pot with the proper, maybe 4, as you say, millimeters non-compliant balloon. But now the stent is sized by the distal main branch, which is 3.5, as you could see in the QCA analysis. This stent is really excellent in crossability, flexibility, conformability, and the good thing for bifurcations is that it has a open cell to link design to allow a very good side branch access. He allows even over expansion. A 3.54, a platform like this could be overexpanded.
What is the length?
It's 18 millimeters. Yes, okay. 18 because I saw that 20 was okay or a bit large, a bit long, sorry. Then 18 was okay.
Okay, so you see on the screen simulation with a bench with the 2 wires in place and the stent deployed. I think time is very important also to have a fully expansion of the stents.
I like to do 2 dilatations because I always see a further expansion in the second. Always I do 2. Yeah.
And you know, we learned from Gérard Finet that when you do a second time inflation, the balloon is a little bit bigger at the same pressure.
Yeah.
So it increases a little bit the size of the balloon.
Exactly. We are going to 12, 14, then we are going from 3.6, 3.7.
So what is interesting, we see that on the bench, is that after a full deployment of the stents, of course, you have a poor apposition of the stent proximal to the bifurcation. And we can see the space that we have proximal to the carina.
This is the result after the stenting. Okay. As suspected, the side branch is a bit pinched, and we had the carina shift, and we have now to open the side branch.
Will you perform proximal optimization before?
Yes, we are going to do first. Yeah. We are going selecting the balloon. I was looking that we have here a 4 because we have an 18 millimeters balloon, and I think that 12 millimeters are proximal to the carina. We're going to use this non-compliant balloon, this AQ-Force Monterumo balloon, non-compliant, 4 millimeters and 12 in length. We're going to place the balloon exactly proximal to the carina as the pod should be done. And the pod is important because you restore the geometry, as Thierry explains very well in his presentations, and you can facilitate side branch access through the proper distal cell. I'm going to keep both wires, and I'm going to use a third one. See, we are just placing the balloon in a non-compliant. I repeat, look at this malposition because now it crossed in. Sometimes when it's an indication that you have malposition proximal and you need the pod because the balloon is crushing against the proximal edge of the stent. This is the point for exactly, ahí, 6. We are proximal to the carina. Dale ahí otra vez, a 8. Now it's better. Vale. Now we have the pod, which is done.
So of course, it's very important to do the pod at the right place, up to the proximal part of the stent, but also very close to the carina because this is where you will access toward the side branch with the third wire.
Yep.
So sometimes you have to do several pods in order to be able to have an optimal apposition up to the proximal part of the stent.
Okay, in order to cross, you have to be really pretty sure that you are not malposition behind the stent. Then we go from distal to proximal. Vete dando chispi. Contrast. Dale ahí.
Yeah, I think it's a very important step. Just the pullback technique, so orientation of the wire towards the side branch, and pullback, and it's jumping in the side branch.
Okay, we just cross there. We can remove the other wire, which is this one.
Very nice demonstration of the pullback technique. Of course, you can use a wire from the main branch, but in this particular case, I think using a third wire is safer because access toward the circ is a little bit more complex as compared to LED diagonal bifurcation, for example.
You're right. We sometimes use the wire in the main branch distally, but I don't know. I would like to have the wire of the stand always there, and when I rewire, I get a confirmation that this is in the true stand lumen going very distally. And then if I am very distally without problems and the wire is moving very free, you are pretty sure that you are not behind the stand, and you can go in the pullback technique to crossing to rewire.
Yeah.
So,
and also because you have done a good proximal optimization technique, the
yes,
risk of outside is very low.
The rear ray balloon crossed the cells easily, smoothly, no feeling of resistance. You know, you can see the marker of the balloon. I like to start with a small balloon.
So what is the size of the
It's 1.5, just 1.5.
Ah, okay.
Ahora prepara un 2,5.
So is the plan to use semi-compliant or non-compliant balloon for?
For the first, we're using the 1.5. Now we're going to use a 2.5, and this is semi-compliant because we are going to use it for the kissing afterwards.
Okay.
And I should because there was no calcium, and I am not so concerned about expansion. But if I see any kind of sub-expansion in this balloon, immediately you can move to a non-compliant balloon. AQ-Force is a non-compliant balloon with a good profile, but there are others non-compliant balloons that are not so friendly, and sometimes it's, the tip is the balloon is thicker, the tip is not so good. The tip of this stand, the Ultimaster, for example, is a very good tip because it's designed to prevent cracking, flaring, hand nailing. It's very tapered. Look at the balloon is crossing without any problem. Okay, we are there. Look at, this is just 8, and we have a good expansion, 10, 10, 10. We have to do, the new generations, they do inflations, very short inflations. They implant the stands in just 4 seconds. I think we have to keep the balloons inflated for a while, for longer, not just so fast. Because you see the gain with time. You see the gain with time. This is more dilated than at the beginning of the inflation. If I do all the cine, you can see that now it's more inflated at the beginning. I didn't change the pressure.
So what we can see in the bench is that when you inflate the balloon, you went through the strut, you have attraction of the stents opposite to the origin of the side branch. This is why we should do a final kiss or at least a repot at this at the level of the carina. I have to say that usually I use directly the AQ-Force, a short AQ-Force balloon for the side branch without pre-dilatation with any balloon, because in the majority of cases you are able to cross without any difficulty. So now you will kiss with 2.5 in the side branch and 3.5 in the main.
3.5 in the main. A ver, venga, sube. 2, 4, 6. A la vez que yo. 6. 6. Sube, hija, sube. 6, 8. Sube 8. 8. Déjame a mí este. Now it's better?
Yeah.
Okay, we predilate more with this. Yes. And let's do an again. A new, venga, come on. Venga, sube, conmigo. Sube. 6, 4, 6, tú 8. 8, 10.
It looks good, though. So what is important when you do the keys is to have a simultaneous deflation at the end.
Okay.
In order to have the carena which stay in the middle of the bifurcation.
Vamos a retirar.
So what is the next step? Will you do a repot or go directly?
I'm going to do repot. You need to do repot because we have the 4 balloon, but please, because as you say, we have to restore the circularity. The kissing is induces the kissing induces eccentricity of the proximal stand, and we need to circularize again the proximal, the 4, el balón de 4.
Yeah, I fully agree. Of course, we cannot see that on the screen, on the angio, but
exactly. In the angio, you would say it's fine, we finished, it's okay, but it's not. It's not. It's not.
I agree. Especially if you use long balloons. Of course, if you use a short balloon and you do the only in the polygon of confluence, maybe you don't need to do a repot. But if you use long balloons, you have to do it because you have a bottleneck effect proximal to the carena.
This is going to be the sequence: pot, kissing, pot. Other people do sometimes pot, side branch, pot. But I think the kissing was important here because it was a large main side branch.
Yeah.
And you need to have a good result. It's important to say that the balloons were large because 3.5 and 2.5 through a 6 French, and I didn't feel any resistance or difficulty in the positioning and placing of the balloons. That is a good thing about the balloons. Rear ray and acute force. Again, it's important to tolerance for overexpansion of these stands because in this case, the stand proximally maybe is going up to 5, but the large platform on the Ultimaster Tensei tolerates up to 5.8, which is really large. Yeah.
So this balloon is 4012?
Yes.
The same as before, yeah.
12. It's important to do the pod, as you say, very exactly in the position because you see this very distal. You, again, displace everything to the side branch and you pinch the side branch again. If it is too proximal, you don't do the job in the polygon of confluence, then you have to be in the right point.
Yeah.
It has to be in the right point. Okay, prepare the of the eye. We are going to do the of the eye. Now, when we have the stenting, we have the science branch work done. And we're going to do some projections. And we are preparing the Luna wave for FDI and the catheter to check internally. That should be done in large bifurcations, particularly like this or the lead main. It's very important to have imaging. What do you think of the result, Yves?
It looks very good.
I think it's good. You should not nice. Exactly. You should not expect a 0% stenosis in the side branch, but in this case is less than 30%, and I think is adequate because some people feel the temptation of stenting very easily.
And with the nice technique that you have used, I will be surprised to see something unperfect from OFDI.
Okay.
Yeah, it looks very good.
I guess go to do the OFDI. We did the pull back.
Yeah.
And I don't know, maybe you can you see it, the OFDI run?
Yeah, absolutely.
Oh, good. Vamos a retirar el catéter, no hace falta más imagen. No, de entrada no, retira. Retira. OFDI, you can adjust the length to run, to examine, it's very good. And muestra. We're going to show this distal edge. Very important to see if any dissection. You can see the vessel. No dissection in distal edge. Some with the distal. No, this is the stent, distal. That's it. Okay, go. Go. This is the distal vessel, healthy vessel. This is the stent. Nicely opposed and expanded.
Yeah, good transition.
You see, look at the bifurcation, the other wire. Of course, and eccentricity in the polygon where the plaque was. And very, very, very mild malapposition. Vete al proximal, vete proximal. And you know that you can tolerate some minor degrees of malapposition because look at, stop there, stop, no, before. Just there, stop. Mide del estrato la pared. If you measure the maximal distance, is so tiny that it's 0.15, 0.1. Yeah. Really, is nothing. And the risk of going more aggressive in these cases is maybe to dissect or even rupture a healthy vessel at that point. What do you think, Thierry, with this very, very tiny, small malapposition?
No, I fully agree. I will not touch this. We know that it's not an issue. We need to have really a malapposition in terms of surface. I think it's better. But in this case, it looks perfect for me.
Show again,
this
please.
Part, proximal part, bifurcation.
We're going to show the most important, the critical, where we can see the, look at, where's the minimal area there? There, that's that point, 8.6, which is excellent minimum stain area for a circumflex, which is really good. Even will be good for many left mains. 8.6 is excellent. Any further intention to enlarge that point could be in detriment of the side branch. We have to keep this in mind. And 8.6 is an excellent area. The diameters are, you can see 3.83, the diameters at that point. So, muévete la bifurcación again. We're going to see where the circumflex is. Look at there, look at the wire is coming up at 12. Go para allá. Proximally. Look at there. Good opening to the circ and a good lumen. Then, Thierry, I think we finish.
Absolutely, I like it very much.
And let's place the wire there. I like to place the wire in a safe position, just doing the final angios. In case of a suboptimal side branch result, we were discussing that maybe the alternative would have been, of course, to do T or tap in this case.
Absolutely.
Good. Other alternative, if the side branch would have been more affected, is to do an inverted provisional. It's a suggestion that Thierry made, a very, very convenient suggestion, because sometimes it's not common at all, but sometimes it's the inverted provisional, not Thierry, is when the side branch is really very diseased and maybe you and the distal main branch is much more healthy. Maybe the inverted provisional could be an alternative.
Yeah. Absolutely, but in this case, I think the strategy was the best one. Of course, if needed, you can add a stent in a T-shaped configuration or tap if you are not sure about the ostial positioning of the stent. I think it's really a very good result. So maybe time to conclude the session.
Yes, we can conclude the session. It's a 101 bifurcation in a large vessel. In this case, we opted for the most common strategy in the large EULT master registry, which is over near 40,000 patients. In bifurcations, near 80% of cases were treated with provisional, 76%. Then we follow the most common strategy nowadays, which is currently the provisional. We predilated the main branch. Then we stented the main branch according to the distal. We did the pot with the 4 millimeters. Then we rewired the side branch, which is really important to do it properly through the distal. And after rewiring, we dilated the side branch, the cells that send to the side branch. And we finished with a kissing balloon, properly sized, and finally a pot. The sequence is pot, kissing pot, which is really the sequence that is more I could say, indicated in cases like this. Then with only one stent, very good stent for this kind of lesions, we just fixed the lesion of this kind patient.
Yeah,
we also showed
much.
the utility of the CT, of the eye, because if the eye confirms the good result that angiography is not so sensitive to show.
Thank you very much, Jose. I think it was an excellent demonstration with a very interesting case and a very nice result.
Thank you.
Thank you. Bye-bye.
Bye.
Good afternoon and welcome to this Abbott-sponsored symposium, which is part of EBC 2020. My name's Adrian Banning and I work in Oxford in England. It is my pleasure to be joined by Carlos Colett from Aalst, Nicolas Amabile from Paris, and Gabor Toth from Graz in Austria. And we're going to talk about complex bifurcations, combining the latest evidence and tools to simplify your treatment. We're looking forward to understanding slightly better some of the pathology that's going on in this particular patient's bifurcation and exploring how imaging can help guide our therapeutic approach. So perhaps without further ado, let's ask Carlos to show us the case and we can try and understand a little more about what the challenges are. Carlos, thanks very much for presenting the case. We look forward to hearing your presentation.
Thank you, Professor Banning, for this introduction. And indeed, we have prepared an OCT-guided bifurcation stenting that we consider to be very complex, not only in terms of technique, but also on the pathology that lies behind the case that we're going to show in the next slide. So this was a 70-year-old male with a BMI of 25, typical risk factors, hyperlipidemia, hypertension, ex-smoker. He presented with stable angina class 3, and relevant past medical history was an anterior MI in 2003 that was treated with a PCI, with the LAD and the diagonal branch, and this was a two-stent strategy back then. Concerning the paraclinical information, normal renal function and normal ventricular function. This was the ECG before the procedure. You'll see normal appearance of the anterior wall in terms of thinking of the previous STEMI. This is the angio. You'll see immediately that there is a stent in the LAD and you'll see a severe restenosis just at the ostium of that diagonal branch, which is a big diagonal branch. You see not only it's in size, but also in extension in the length of the vessel. And you will see a very critical lesion at the level of the bifurcation. This is our in-stent restenosis, Medina 111. This is the still image to appreciate a little bit better the morphology of this severe angiographic stenosis, which has the very minimal luminal diameter at the level of the bifurcation. But if you go also proximally in the LAD, you will see that the disease comes from the proximal part of the vessel, almost from the ostial of this LAD. So we perform an OCT to better understand the pathology of this in-stent restenosis. This was a very challenging OCT acquisition, but we didn't want it to predilate the vessel to better understand what was indeed the cause of the restenosis. So we did a double injection. This means from the catheter and also from the flushing port of the OCT catheter to be able to opacify the vessel distal to the stenosis. And this is what we got. We got, these are the cross-sections. You will see cross-section A in the very proximal part of the LAD, which is a huge vessel. Not healthy. You will see a couple of calcified plaques there at 12 and coming from 12 to 4 o'clock. Then you see cross-section B, which is actually at the level of the minimal lumen area. It was 0.68, a very tight luminal area there at the level of the bifurcation. And you see the appearance of this restenotic lesion, which we will discuss further on with the expert. You will see this heterogeneous appearance of this, what appears to be severe neointima hyperplasia. Then you will go down across section C, and we were happy to see that we could see the entry of the diagonal branch. You will see that at 6 o'clock, and you also see the stent struts. And in this cross section, it appears that we have some under expansion at the level of the take of the diagonal branch. And finally, cross section D, which also showed the previous stent that was implanted with a mild amount of neointimal hyperplasia. This is the 3D reconstruction coming from the OCT, again, to try to identify the position of the ostium that we thought was the most challenging part of the procedure.
So I guess the questions for me are, and you may not know this, Carlos, and often we don't, what do we know what bifurcation technique was used in the original revascularization?
Yeah, we didn't have that information, unfortunately. So we were not aware. We thought it was a tap by the configuration of the stent in the angio, but we were not sure of the technique that was used.
I think we can take it as a given that this is an important diagonal. As you've mentioned, it runs long, and we've heard over the years that the length of the diagonal is really very important with regard to predicting whether that's going to be an important diagonal for us to look after. So we do want to try and get a good result, a good angiographic result, and more importantly, a good functional result in the diagonal, as well as the LAD. And I guess the other question is, can we wire it? And on the angiogram, and certainly on the OCT, you would think, yeah, it looks okay to wire. Everybody has their own preference. For me, I always wire the most difficult lesion first. And so my wire would go into the diagonal first. I probably wouldn't predilate to begin with, and I would just try and get my 2 wires in. But you can see from the RAO projection in the angiogram, it certainly looks pretty tight. Perhaps before we talk about the PCI options, we should just go through the process of confirming that PCI is the way forward. Nicholas, is your view PCI or surgery? How would you judge that?
Adrian, I think that's a great case. It's a very challenging situation, and my initial plan would not to treat this patient with cabbage, but rather do a PCI. And so, of course, the challenge is that there is already one layer of struts within the artery. So I would try not to put other stents in this previous stent, and maybe analyze the reason for the in-stent restenosis and potentially go for drug-eluting balloon after OCT and potentially also post-dilate the previous stent.
Great, thanks, Nicholas. I guess, the key question for me here is whether the initial stents are properly expanded or not, and what the contribution of in-stent restenosis is. It's interesting that this is, this is a long time since the stents were placed, so it's slightly unusual presentation. This is some 10 years or so, I think, since the original stents. So imaging, Gabor, for you, I mean, sometimes we are perhaps put off imaging when the disease is complex. Do you think imaging is mandatory in this case?
Yeah, I think it's a real challenging case, but we are facing more often such cases where the patient comes with a restenosis and a bifurcation, and you have no information about what kind of technique was used. And I believe in such cases, imaging can be really helpful. It was demonstrated here by Carlos that we don't see much double or triple layer in the proximal main branch, which helps us actually to exclude more or less DK Crush's previous technique or Collett's previous technique. So we can assume that it was probably a T with very small or almost no protrusion. And so for this reason, I believe it was a huge help to see with the imaging as a starting point to understand the previous anatomy. As shown in this slide, which comes from the Light Lab data, Light Lab was, I don't know whether you know or not, Light Lab was actually a project by Abbott where in selected hospitals, very systematic use of OCT was done during all kinds of procedures, following a very strict rules or guidelines, how to do and how to react on different findings. As you can see here, even in bifurcations, it was quite large number of cases where the OCT-derived information completely changed the practice or changed the previous strategy of the operators as it was used before the PCI or during the PCI. I'm sure that in this case, the use of imaging, it helped a lot to clarify some unanswered questions of the end.
Carlos, just tell us again how you managed to get such good pictures in this very tight, very severe stenosis.
Well, that was, I'm going to disclose the technique, and this was taught to me by Dr. De Bruin. And we use the port that we normally use to flush the OCT catheter, and then we inject at the same time through the guiding catheter and through the port of the OCT catheter. So this allows to opacify proximal to the severe stenosis and distal to the severe stenosis, and then you manually start your OCT pullback, so you have a complete picture of the vessel, even in severe lesions.
And the patients tolerate that pretty well?
Pretty well. We have no issue with the patients with this technique.
Great, because they are spectacular pictures given the severity of the stenosis. Nicholas, drug-eluting balloon versus a second stent. Clearly, because this is, I guess in this case, a third stent, because this is a bifurcation, it does have a, we've all put stents, 2 more stents inside 2 existing stents, but it can be difficult, particularly maintaining wire access to the branches. Which technique would you favor? Would you prefer to try and treat this with a drug-eluting balloon if at all possible?
I think when we get instant restenosis, it's very important to perform a RCT to analyze first if it's new intimal hyperplasia or if it is new atherosclerosis, because then the treatment will be quite different. And so also to analyze the reason for intrastent restenosis. So that's why I think that RCT is quite indicated, and especially in bifurcation, because it will really help the operator to get a better choice for the treatment. And so in case of first episode of intrastent restenosis related to hyperplasia, neointimal hyperplasia, drug-eluting balloon is a quite correct stent. But in case of new atherosclerosis, I would personally go more for a drug-eluting stent.
Great. So Carlos, you've heard the opinions of our colleagues there. I think broadly you have strong support for the approach with regard to imaging. And I think we all feel that if we can avoid putting further stents into this bifurcation, that would be preferable. I guess the fact that we think that based on the OCT, this may be a TAP or perhaps a T, more likely a TAP, I guess. I guess it possibly implies that wiring may be slightly more difficult. But let's see what you said. Also, you said you did.
So I think we are in agreement with the panel, and this is exactly what we plan to do. So the plan was to wire the main vessel, to wire the side branch, to pre-dilate both branches and finish the procedure with a drug-coated balloon for the main branch and the side branch, and then do a final OCT run to assure that the stents were well apposed and we didn't have any areas of other expansion. So we really agree with the notion that we have to avoid an extra layer of stent in a bifurcation that was already treated with 2 stents. So this is what we did. So we started wiring the main branch, which was fairly easy, and we did a pre-dilatation the main branch with a 2.5 15 balloon, and then we went a little bit higher with a 3.5 20 balloon. This is for the main vessel. But we have some issues accessing the side branch, and we tried initially with normal wires. Then we decided to park the balloon just distal to the takeoff of the side branch to see if this would help. And then we start trying different wires. Start with a BMW, then we change to a Whisper, then we use a Pilot, then we use another time a BMW, but none of these wires would go into the diagonal. We went into, we used a filter as well, and it didn't work. So finally, we decided to use a microcatheter, a Super Cross from Teleflex, which has a 120 degrees angulated tip. And using this, this microcatheter oriented towards the ulcin of the side branch and using a Gaia first, we were able to go inside the diagonal, as you see in the right picture of the iliocranial. We will finally were inside the side branch. We had some issues trying to cross this side branch with the balloon. So we use a guide extension. You see the guide extension there coming inside. We started with a small balloon at 2.08. And this is the first angiographic result that we had in the side branch. So we were really happy that we were able to cross the side branch, and we have good flow with a relatively good angiographic appearance at this stage of the procedure. So we started to increase the size of the balloon. We did another pre-dilatation at the ostium of the side branch with a 2.015. And then we did a kissing with a 2.5 in the side branch and a 3.5 in the main branch. And let me show you, then we decided to continue the procedure with a drug-coating balloon in the main branch. This was actually to avoid the exfoliation of a stent. And we performed an OCT after the drug-coating balloon in the main branch. This is the run of the OCT. And when we look at the still pictures, this is what we observe. You see, if we start from the distal part of the vessel at cross-section D, you will see that you can identify some of the previous struts that were implanted, and we have a small dissections at 6 o'clock. If we move a little bit more proximal towards the ostium of the side branch, you will see that we have a dissection which was inside the previous implanted stent. That means a dissection in the neointimal hyperplasia with some thrombus and thrombotic appearance at this stage, and you see the ostium of the side branch at 6, 7. But in the most proximal part of the vessel in the LAD, we have a huge dissection, and you can see that in cross-section B and cross-section A. We think that this was due to the guide extension that went pretty deep into the LAD to be able to cross the diagonal branch. So finally, we decided to implant another stent proximally, and this is we implanted a Sierra, a 4.018 guided by OCT. And here is the last run of the OCT in the main branch that show a very good expansion of both the previous and the new implanted stent and no areas of malapposition. If we look now at the still pictures of the same final run, this is what we obtained with an MSA at the level of cross-section C of 8.74 millimeters square. And this was the final angiographic appearance, which for us, it was really gratifying to see a very good flow in both branches and a good result at the level of the side branch and at the main branch as well. Finally, the patient did well. Small increase in troponin after the procedure, 30.6, and small changes in the anterior wall, but without pain and without further increase in heart enzymes.
That's a great case. And I think one of the things in intervention that we love, of course, is that there are guidelines where we must do stuff, or at least we feel very strongly that this is the way to do stuff. And then there's lots of elements where, our practice is more of an art than a science. And I guess what interested me was that you chose to kind of be quite aggressive with the main branch before trying to wire the side branch. Were you surprised then? What do you think the mechanism, why was it so difficult to wire the side branch when actually, on the OCT originally, we thought the side branch looked as if you could see down there. Did that surprise you? Did you feel that you were behind something?
Well, we had the impression that when we start changing the wires and we finally went with the Gaia one that has 1.7 grams of the tip, that we were kind of puncturing through something. It was not a smooth cross towards the side branch. And when we actually passed the wire through the distal part of the side branch, we were kind of confirming that we really were in the true lumen, and we're a bit afraid that we were maybe in suboptimal space because of the feeling when we went into the very ostium. So I'm not completely sure that we actually went to the small lumen that we saw in the pre-PCI OCT, but we indeed found another channel to go into the distal part of that big diagonal.
And as you say, it's all then about making sure that it doesn't really matter to a certain extent, as long as we get into the distal lumen, and then making sure that we've expanded the area of the bifurcation and the carina optimally, and you obviously got nice images with that. And then making sure that the main branch is right. And I think one of the things that we sometimes, one of the risks here is that we get our eyes completely transfixed on the ostium of the diagonal, and we forget that actually, making sure that the main branch proximally is optimized is hugely important, and there's lots of obvious good data confirming that statement. So Gaba, what were your thoughts about the way that this is, the way that Carlos has managed to treat this bifurcation?
It's a different story as compared to when you see a native de novo stenosis and you have to select the technique. this patient has already a layer of stents in the side branch, a layer of stents in the main branch, and now you just go to optimize or at least could correct the results of that. I think the most important thing here is to avoid adding multiple layers to that. So I think the approach with the balloon and drug-eluting balloon is a really good choice. Of course, you have to see whether after lesion preparation you have a good enough result to go on with drug-eluting balloon. But as long as the lesion preparation allows you with its result to go for drug-eluting balloon, I think limiting the layer of metals, it's a very good choice. Yes, so my question is that you used OCT in the main branch after lesion preparation, but you did not use it after wiring the side branch. And wiring the side branch was extremely challenging, as you demonstrated, different wires, different techniques. And in case of complex bifurcation, my greatest doubt is always whether I wire the side branch properly, or in this case, when you have already a stent in main branch, stent in side branch, I would have fear that I might wire the side branch behind struts or not through the cell what I really wanted to. So I believe imaging after side branch wiring is a very, very good way to understand what we really did, whether we placed the wire to the proper direction. So my question is whether you considered to do this, or you were confident enough that your wiring was through the right direction.
I guess, Carlos, before you answer that, it was a question really of having struggled that hard to get it in, that's where it was going to be. It wasn't as if, I suspect you were unlikely to pull it back out and try and redo it once you'd finally got in there with your fifth wire. But tell us what you think.
So I think imaging the side branch is, it was something that we thought in the procedure. We even tried to pass the OCT catheters to the side branch, but it was not possible. There was something at the osseum of the side branch that impeded the OCT catheter to go through. So we didn't try a lot, to be honest, because we didn't want to, we want to preserve our OCT catheter, and this was all through a guide liner. So we decided to stop pushing the OCT in the side branch and just rely on the angiographic result.
Carlos, I've got a question for you. Would you consider about, if you go for drug-eluting balloon, do you consider just treating the main vessel, or would you also treat the side branch with drug-eluting balloon? And if not, okay, could you explain us why only the main vessel?
That is a very good question, Nicola. And the initial idea was to do a drug-coating balloon also at the level of the side branch. But again, we had a lot of difficulties pushing down the drug-coating balloon for the side branch. So we decided to do normal balloon for the side branch that looked pretty good angiographically, and end up with a drug-coating balloon only at the main branch.
I think one of the relevant comments I would make about that is, going back to the natural history of this, it's quite possible that there's been an element of restenosis here for some years. This is not a procedure that was done 9 months ago. This was a procedure that was done many years ago. And it may be that this patient's been pretty well with an angiographic result, which was not perfect for a long time. That I think has a bearing on my approach here, that I might not be looking for angiographic perfection. I want that diagonal to be open, and I want it to be as good as it can be, but I'm not striving for angiographic perfection in the branch. I want to make sure that the main LAD is absolutely optimized. So, Gabor, you have a question for Carlos?
Yeah, my question would be here. Actually, no, it's not even a question. It's more a comment that I believe that with imaging, you understood very well what is the extent of what is the extent of proximal dissection, and to what extent you need to stand proximally to cover it. I believe it was again a kind of confirmation what we have seen on the angio and confirmed by OCT. I think here again post PCI OCT might add some important information regarding how far you need to post dilate and optimize the stent result. final question is again that you have a very nice results proximally and in the main branch, but whether you consider to do OCT in the side branch as well at the final result, just to understand whether you have a good position all over the bifurcation.
Thanks, Gabo.
So yeah, we're really happy with the results on the main branch, and just to give kind of a summary of where the level of decision in this case. First, we identified that it was neointima hyperplasia. Then we were confident to use the drug-coating balloon. Then came all the technical difficulty of the procedure, but then we finished with an OCT that showed a very extensive dissection. And as you mentioned, Gabor, the length of the dissection was extremely important for us to select the length of the diameter. The next critical question at that level was, until when are we going to put the stent in the proximal LAD? So we aim to have a small amount of overlapping with the previous implanted stent. And this was kind of the decision that we took at that moment. The side branch looked pretty well. We have a very good flow. Angiographically, the ostium was not tight at all. So we were really confident that the result of the side branch was good. So we decided to end the procedure with the OCT in the main branch.
I mean, the other thing which is quite nice is that you accepted a little bit of a dissection distally on the OCT without feeling the need to put another stent in. And one of the criticisms of OCT is that we see too much and that we are kind of driven consequently to put in stents when they're not necessarily required, and that we can see small dissections, and perhaps less experienced colleagues might be tempted to put more stents in just because there's a dissection. Is that what, do you want to make a comment on that, Carlos?
Yeah, that was absolutely crucial, Professor Banning. The decision of the length of the stent in the main branch at the final run was something that we stopped for a bit, discussed with the colleagues that were also on the table to decide, okay, we have a long dissection. Actually, in the distal part is within the previous stent. It's not a big dissection, but the proximal LAD, that is, let's say, a de novo lesion, has a huge dissection. And then it came the discussion from where to where. And then we decided to cover the big dissection and then just landed just a few millimeters overlapping with the previous one and leaving, as you mentioned, small dissection in the distal stent untreated.
Nice. So going forward, dual antiplatelet therapy, and increasingly we have the option because of the stent technology we now have to start to tailor the duration of dual antiplatelet therapy for our patient and for the stent and for the procedure that we've undertaken. So, Nicholas, how would you kind of balance the requirements for this particular patient?
I was, of course, in this case, in this kind of patient, is a stable patient, so we treat him with a drug-eluting balloon and drug-eluting stent, and 6 months might be enough according to the European guidelines. On the other end is a bifurcation, so there's a high risk. There is a high risk for a recurrent ischemia, and so we could potentially consider longer DAPT, especially because the bleeding risk of this patient is quite low. But I was also very interested by the OCT image that Carlos showed, and especially with the thrombus on the struts or the protruding material just at the carina. And I was wondering if it could, if it will influence his peri-procedural anticoagulation regimen, if we'll go for more heparin or maybe a more aggressive DAPT strategy.
Yeah, so intraprocedural, when we see this amount of thrombus OCT, it's like a reflex, and we take immediately an ACT. We see thrombus, take an ACT, and most of the time it's a bit low, so we indeed add a bit of heparin to the procedure. That is something that we kind of, it's a reflex now in the cath lab for us. Concerning the APT, we had the impression this is a gentleman with a complex stenting. We dilated the struts of a previous 2 stent techniques that we're not really sure what it was. We ended up with a proximal stent with some residual dissections. In that sense, we prescribed the APT for 12 months for this gentleman.
Yeah, I mean, that sounds very sensible. Particularly, I think it's easy to forget, in a case like this, you've got a guideline, a catheter in, you've got OCT catheters in, that the potential for thrombus obviously, in the lesion is one thing, but the potential for thrombus in our equipment is another that we need to be very, very careful about. And you know, when we're doing these complex cases, serial ACT measurements are obviously very important. Well, I think we've really learned a lot from that case. Carlos, thank you very, very much for bringing it to us. And thanks very much to Gabor and Nicholas and to Abbott for sponsoring this session. I think what we've seen here is examples really of the kind of cases that we now, I guess, are the new routine. We don't have all the information about how this patient was treated some years ago, and how we, by using OCT in this particular case, took a case which was complex, got some really informative images from OCT, and that then allowed us to do ultimately what was quite a simple procedure. You know, we haven't made it more complicated than it needed to be. We've ensured that the main LED has been absolutely optimized. We've ensured that that stent's been put in properly, and that we've got as good a result as we can achieve in a pragmatic way in this bifurcation. So a great example, I think, of how using technology, we ultimately managed to keep it pretty simple. So with that, I'll thank you for your attention, and I hope you enjoy the rest of the virtual EBC 2020.
Good afternoon, everybody, and very welcome to the pitfall and troubleshooting session in bifurcation PCI. It's a great pleasure to have you on board here today. With us, we have a distinguished panel of a lot of distinguished colleagues who you can see in the small panel on the right side. And having said that, I'll just think that we should move forward to the pre-recorded talks, and then prepare all of you to the half-an-hour discussion afterwards. Good afternoon. I would actually go through the initial part of this session by introducing the EBC philosophy of bifurcation stenting. It's a great pleasure to announce that the 5th TEENS consensus document is out just yesterday in Uribe bifurcation, and one of the issues in that paper is actually a discussion of the pro and cons of different bifurcation stenting techniques. Over the years, the possible useful stenting techniques have been reduced to a few, which is actually manufactured for special issues. On one side, we have the provisional pathway with provisional stenting ending up with maybe a T, tap, or a culotte, or we have the upfront two-stent technique, the DK crush. But there are differences. For the one-stent technique in the provisional pathway, there is risk of closing the side branch. If it's inverted, conducted, it's actually bearing the risk of occluding the main branch. And the distal main vessel patency in the reverse pathway is actually dependent on the stent site cell where to cross. And the distal integrity is also extremely important when the procedure is done reversed. There's a risk of dissection and losing the main branch. On the other hand, in the two-stent techniques, if we go further on with the tap, there will be attention to the side branch stent implantation to avoid too long protrusion of the side branch ostium. There will be multiple steps in the culotte stenting, and there will be a double stent layer in the proximal main vessel. And if we go for the upfront DK crush two-stent techniques, multiple stents is required. And so far, efficacy is only proven when practiced by operators with high experience with this technique, and it will end up with stent layers of triple in the lateral wall of the proximal main vessel. But due to all these concerns, we have actually planned this session today to run through the different techniques and to focus on where you have to pay attention and why and how it's possible and reasonable to solve problems should they occur during the procedure. So again, back to the EBC philosophy of the provisional pathway, which is actually formulated quite nicely by the Danish philosopher Søren Kierkegaard. Life can only be understood backwards, but it must be lived forwards, which means that you really can't predict a procedure. You need to embark on it, and then you need to have in your toolbox all the different tools to solve problems you may face during the path, to have the best possible end result, which will save and secure the patient for the future. So this is actually the dilemma and the reason why EBC promotes a stenting philosophy that moves forward stepwise and can be stopped and kept as simple as possible at each procedure. By having said this, we will move forward to the first of the part of the session on pitfalls and troubleshooting. And this will be the provisional pathway. First of all, we have to look into the anatomy of coronary arteries. It is a fact that coronary arteries divide in a fractal manner. In this picture, you can see different pictures from Google Earth looking down at rivers. There's tons and tons in the internet if you like to go through it, but you will see very, very easily, especially in the upper panel, that if you making a photo from 2 kilometers height, as at the left, you'll see the division like it is for a coronary epicardial artery. If you magnify it a bit more, you'll see actually what conducts down to the conducting vessel. And if you go even further, as you can see on your far right, you'll see down as the capillaries. But that law of nature, or what we should call it, is actually exactly the same in the coronary arteries as it is in this riverbed. Down below, you can see a very, very nice picture of a Malaysian river, which is actually, again, a picture of how a coronary epicardial vessel looks like. So the coronary arteries divides in a fractal manner. But there are some other laws of nature and biology behind. Basically, mostly in depth investigated by C.D. Murray in 1926 and published in Physiology. And the conclusion was that the diameter of the branches in dividing coronary arteries correlates to the physical principle of minimal workload. And if you have a chance, I would actually encourage you to look into the original papers, which is quite nice readings from 100 years ago. The fact is that when these laws of biology is applied on the coronary arteries, it's very easily seen that when a coronary artery divides in two, it will end up with smaller diameters in the distal part. This is actually investigated in more depth by Girard-Finet and by our colleagues Hugh and Cassatt and their laws of the relation between the side branches, the main branches in the distal part, and the main branch in the proximal part. But the implication of this is actually very, very important to be aware of when we are going to go through the technical issues of bifurcation stenting. This is a cartoon depicting the tapering nature of coronary arteries and the consequences in PCI. In the first panel A, you can see a side branch takeoff and a tapered vessel. This is actually caricated a bit, but just to make it totally intuitively understandable that when you like to treat a lesion like in panel A, and you use a tubular stent with the same diameter in the top and the bottom, and implant it across the takeoff of the side branch, you will end in a situation with B, where you actually make a tapered coronary vessel untapered by overstretching the distal part below the takeoff of the side branch. And the consequences in B is just depicted that the dilatation overstretches. In C, you can see the consequences, which is actually an elliptical stretching of the side branch and what we call nipping. You can also, if you look deeper into this picture, see that actually this area, if overdilated, the carina area would go towards the side branch and maybe narrow it and close it. This is the oval expression you saw in this picture. So if we overdilate in the distal part, there is a high risk of deterioration of the ostial area and maybe closure of the side branch. To actually compensate for that, we need to make a tapered stent fit the anatomy, or rather, we make a tubular stent fit the anatomy. And by this, the pot optimization technique was invented by Olivier de Remond. And this is actually, in all its basic settings, put in a stent with respect to the distal diameter, take a larger balloon, respect the carina, and dilate the proximal part of the stent to actually make it covering the vessel wall and make the stent tapered and manufactured to fit the biology. Open the stent struts and finalize with kissing balloons. This is actually the steps promoted by the EBC in the provisional pathway. When we are doing this, there are high risk of problematic situations. First of all, if we go too deep, as we can see in this in this left part of the panel, we will actually overstretch the distal part, press the carina towards the side branch, narrow the ostium, maybe close the vessel, and we will not cover the proximal part of the stent, which will end up in what we could call a bottleneck. So there will be two problems if we go too distal with the pot. If we go too proximal with the pot, we will leave floating struts across the side branch and not opening up sufficiently. But if we place the pot balloon correctly, we will avoid the bottleneck, and we will actually place the shoulders of the balloon across the side branch ostium and open up nicely with an easy access for the next steps. This picture is out of the newly published EBC consensus document, the 15th, which was actually published online during intervention yesterday. So if we go into Visible Heart Lab and by video scope actually go directly and look at the stent implantation, when it's done, you can here see a stent implanted over bifurcation with respect to the distal diameter. And then you see one of the main problems in this technique, which is actually all the floating stent struts in the proximal part. Makes it extremely important not to lose the wires, because the risk is in the next step to go behind the stent and maybe crush it while ballooning the next step. Here we see the pot conducted a larger balloon in the proximal part with respect to the carina. We can actually see how nicely the proximal part of the stent is opposed to the vessel wall. And now the balloon is removed and we have a peak down. And on the left, you can see the takeoff of the side branch, and it's very nicely opening. Make it accessible for wiring, wire the most distal part of the cell struts, and bring in the balloon for the kissing balloon technique. Again, we'll see that in real life, it is a bit different. The balloons are opened, covering the distal area of the carina, leaving the proximal part free, and then removed, and we can again appreciate the very nice result of the opened side branch and the stented area and the carina. Then we do a pot in the proximal part to correct for possible deteriorations we have done by putting in all our devices. And then, oops, this pot was too deep. And this is the second of the caveats in this technique. If we pot too deep, we actually crosses the carina, brings it towards the side branch, ruin the nicely opened area, and have to redo the procedure, do a new kiss, and do a new proximal pot with a more precise placement. So this is actually what we face if we pot too deep. This can, of course, be uncovered by using OCT and other modalities during the stenting. So here we have after correction, the newly created carina, and the final result. So again, the provisional pathway starts with one stent, opening up the side branch if needed, and then the entire area is scaffolded. If we want to put in a second stent, we could do it like a T, like a tap, or like a culotte, but it just depends on how deep we implant the second stent. And these pitfalls and troubleshooting in these part of the procedures will be very well depicted in the following presentations. We have to remember that the provisional pathway can be done both main vessel to main vessel across the side branch, as seen here, but also reversely from the side branch to the main branch. So if we would like to protect the side branch, there is options. This procedure is of course more risky because we are risking and facing the risk of closing the main branch. So we need to have in our toolbox tools to fix the problem if should we close the main branch. This will also be part of the upcoming presentations very soon. So in summary, the provisional stenting is actually a philosophy that develops stepwise and aims at reconstruction of the vessel anatomy and give the possibility to stop at every stage when we are satisfied with the result, but we can end with 2 stents if that bifurcation actually need 2 stents. The first part is for opening the stent struts, the KISS is for positioning of the carina, the second part is for correcting the proximal part of the stent, and 2 deeper part may cross the carina area and leave a bottleneck in the proximal part, and KISS with short balloons make room for more proximal hot balloon placement. So the take-home message is again the stepwise progression of the provisional side branch stenting as promoted by the EBC makes it more possible to stop at any stage in the procedure if the result is satisfying, and thereby reduces the need for 2 stents in the bifurcation and reduces cost and complexity, which is also a very important issue, especially in areas of the world where funds is restricted for the healthcare system. Thank you very much for your attention.
Dear Chairman, thank you for the invitation to present at the European Bifurcation Club meeting 2020. The title of my presentation is The Difficult Side Branch Wiring. One of the most important steps in bifurcation intervention is successful wiring of the side branch for treatment or for protection. Usually, this is performed without difficulty. However, in some anatomical subset and sometime after stenting main vessel, side branch wiring is very challenging. To start with the simple tips and tricks, selecting the optimal view to better see the origin of side branch, selecting and shaping appropriately the guide wire accordingly to side branch angulation, lesion morphology, and anatomy. The most common types of guide wire tip shaping for bifurcation lesion are shown in this figure. However, there is no standard guide wire shaping that can be recommended for each challenging side branch. Personal operator experience and creativity sometimes can play an important role. Creativity is limited since shaping the wire with more curves is often translated in less maneuverability of the guide wire. After main vessel stenting, we all know that the proximal optimization technique facilitate correct crossing the stent to side branch with a guide wire. But beside these simple tips and tricks, different alternative techniques have been described based on case report or small studies, including personal operators' experiences. Balloon backstop, reverse wiring technique, double looming catheter, venture catheter, steered deflecting tip guide wire. Balloon backstop technique. Balloon catheter is advanced in main vessel. The balloon is placed soon distally to bifurcation and deflated at low pressure. Then a second wire is advanced to side branch. This wire will be stopped by the inflated balloon and forced to be directed elsewhere. That means toward the orifice side branch, and by gentle maneuver and gentle turning of the wire can be advanced inside branch, as seen in these two examples. However, this maneuver presents some limitation. Of course, the inflation of balloon in main vessel will induce ischemia, and then this maneuver cannot be prolonged. And even it's not recommended in some specific location of the bifurcation, like distal lift main or very proximal LAD bifurcation. Moreover, indecisive side branch can induce damage and dissection on side branch. Reverse wiring technique. The guide wire is smoothly curved to shape a large distal band, J-tip shape, and in some specific anatomical subset, like in extremely angled side branch, a hairpin bend shaping at about 5 centimeters from the tip of the wire is more appropriate to engage side branch. Then shaped wire is advanced in main vessel distally to bifurcation. The wire is pulled back to where the bifurcation due to the hawk-like bend, and the distal tip of the guide wire can engage side branch orifice. When side branch is engaged, the wire is advanced with smooth turning and smooth maneuver into the side branch. Dual lumen catheter technique based on the use of dual lumen microcatheter, rapid exchange lumen and over-the-wire lumen. Over-the-wire lumen with a side exit at 6 to 10 millimeters from the tip of the catheter. Rapid exchange lumen is on main vessel wire. Over-the-wire lumen is to advance side branch wire. The catheter is advanced in main vessel to place the exit of over-the-wire lumen in front of side branch. Then a wire can be advanced to side branch into the over-the-wire lumen. Can also be used to deliver a wire with hairpin or other specific bend distally to bifurcation for retrograde rewiring. Main limitation may be of limited value in extreme angulation or severe side branch osteostenosis, saying catheter orientation is not completely under control. We have a variety of microcatheter with dual lumen, as you can see in this figure, like Twin Pass, Kaneka Crusade, and Asahi Suzuki, Fine Duo, and other, of course, are present in the daily clinical practice. Venture catheter, 014 wire compatible catheter with deflectable tip. The tip can be oriented and deflected up to 90 degrees and well controlled by a knob on the proximal handle of the catheter. Catheter tip directed to side branch or directly into the side branch, and then the wire can be advanced to side branch. Limitation of this catheter is that requires specific experience. Tip deflection is unpredictable in terms of direction, cannot be used in relatively small vessels, and risk of vessel injury with deflection of the tip. Steric deflecting tip guide wire, 0.14-inch guide wire with flexible radiopaque platinum alloy core on the distal tip. Distal tip is deflectable bidirectionally by proximal handle mechanism on the guide wire. Similar mechanism to the venture catheter can be guided into severely angulated side branch. Limitation. Maneuverability of this wire can be much more difficult as compared to conventional wires, and deflectable tip may predispose to vessel injury as described for the venture catheter. Finally, sometimes could be necessary to predilate the main vessel. This is when, particularly when we have a very tight lesion proximal to bifurcation on the main vessel, because tight lesion and proximally to the bifurcation can make it more difficult to cross with bended wire or to maneuver the bended wire to side branch. So pre-dilatation with a small balloon at low pressure to create more space for bended wire to advance. Following the main vessel dilatation, appropriately shaped wire can be tracked into the bifurcation and access to the side branch. In heavily calcified lesion, rotablation with small bar, 1.25 or 1.5 in main vessel can be performed instead of balloon predilatation. But this maneuver is considered to be a last resort since it can carry a high risk for plaque shifting, plaque dissection, and side branch occlusion. So coming to my take-home message, side branch wiring is essential in bifurcation intervention for protection and for an optimal interventional approach, simple or complex. Side branch access can be technically challenging in different anatomical subsets, like extreme angulation, extreme tortuosity, severe side branch disease. Given the variability of anatomical challenges, there is no standard technique to access side branch. Good experience, appropriate wire selection and shaping play an important role. The techniques described previously may be useful if used in the appropriate anatomical setting and with the required experience. Thank you very much for your attention.
Hello, my name is Maciej Lesiak. I'm from Poznan, Poland, and this is my pleasure to take part in this pitfalls and troubleshooting session. So my job today is to talk on the balloon side branch rescue technique. This is my disclosure. So how to manage abruptly occluded side branch? I mean, the abruptly occluded means that there is no flow at all, so the steam is zero. So first, we usually attempt to rewire through the main vessel stent struts using multiple wires. If it doesn't work, you can try another pot with a larger balloon, but then you will have some troubles with proper balloon positioning because you can't see a side branch ostium. But also, you can try using a jade wire to open the side branch. This is a very nice illustration from Francesco Burzotta paper published a couple of years ago, how to do this. So you can appreciate on the left-hand side the main vessel stent implanted across the stake of the side branch with a jade wire, which is marked in red or pink here. And you can use this wire and insert a low-profile balloon over this jade wire across and push it outside the stent struts down to the artery, to the side branch. And by doing this, you can obtain a flow into the side branch. But before you inflate the balloon in the side branch, this rescue balloon in the side branch, is very reasonable to position the main vessel balloon just to be able to correct the deformation of a stent you may create with the side branch balloon. So on the right hand side, you can see the side branch opening, and once the flow is restored, you can access the side branch through the struts of the stent, after which you can inflate the main vessel balloon and correct the stent deformation. Unfortunately, sometimes it's not enough. You still cannot recross the side branch with a wire, especially if there is some dissection in the side branch. And in this time, you can convert your provisional procedure into the reverse inverted crush technique, which was published a couple of years ago by Manuel Pan group. So this is how to do this. This is inverted crush technique. So once again, you have a jade wire by the main vessel stent. You push the balloon outside the stent struts down over the jade wire to open the side branch. But then you position a big balloon over the jade wire and crush the main vessel stent. And thus, you may have enough room to position a stent into the side branch and do the regular inverted crush technique. So I tried to find some kind of cases in my library, but the only one I found is a little bit different case. So this is a complex LAD diagonal bifurcation I treated many years ago in 81-year-old male patient with quite severe angina class 3. So you see a very diffuse lesion on the LAD with some perhaps involvement of the proximal diagonal. But my approach here was inverted culotte with dedicated stents. So we used that times Triton, which, as you all remember, was the bare metal stent at that time. What I wanted to do was to position the Triton stent in the diagonal branch and then stent the main vessel in the inverted culotte technique. So I started with pre-dilatation, side branch and main vessel with 2.5 balloon. Now you see the Triton stent positioning and implantation, and that's the result after the implantation. Very nice result as for the side branch, but very poor as for the main vessel. So you see that in this situation now, I have a jailed wire. The wire in the LAD is jailed by the Triton stent, and I tried. I made a lot of many attempts to rewire through the Triton stents down to the LAD, and the problem was that with every attempt, my wire was going subintimally, so I was not able to find the right lumen of the LAD, and this is how I came across to this balloon rescue side branch technique, but not actually for the side branch band, but this time for the main vessel. So I used this jailed wire in the LAD, and over this jailed wire, I pushed down the side branch, the small balloon. This is 1.5 balloon over the jailed wire. I managed to open the LAD and predilate the mid portion of the vessel with 2.0 balloon. Then I crushed the stent, protruding Triton stent in main vessel with 2.5 and then 3.0 balloon. So this is the crushing. And finally, I managed to position two stents, the first stent distally to the bifurcation, and the proximal stent, which was 3.0 long stent in the proximal mid portion of the LAD, with pots, keys, and final pot. With this perhaps suboptimal, especially for the mid portion of the LAD result, but at least you can appreciate that the TIMI-free flow is back to the vessel and the patient is safe. So this is, you see at June 2011, so you may think what was the long-term result of this complex procedure, especially considering that the Triton was bare metal stent. So this is a surprise because I managed to check the patient after 21 months. So this is March 2013. And you can appreciate that the long-term result is quite good. There is no restenosis and the flow is okay in both vessels. So just to summarize this technique. So jail wire is the basics of side branch protection. And if you protect your side branch with a wire, you have a lot of advantages of this technique because you can widen the bifurcation angle, you can preserve side branch patency, permit side branch location in case of abrupt occlusion after main vessel stenting, but also, which is very important, this technique allows you to rescue an occluded side branch. Thank you very much for your attention.
Good afternoon. My name is Professor Adrian Banning. I work at the University Hospital in Oxford. This afternoon, I'm going to talk about pot-kiss-pot or pot-side-pot. These are my financial disclosures. So when we consider this question of what is the optimal sequence, pot-kiss-pot or pot-side-pot, I think we have to try and remember what it is we're trying to achieve. This diagram illustrates the important issues which we face when trying to deploy a single stent optimally. Clearly, we need full expansion of the stent with no metallic narrowing and no malapposition, particularly at the carina. Ideally, we'd have an adequate side branch opening with no metallic carina, but what we are trying to achieve is some side protrusion of the stent into the side branch, as you can see on this bench diagram here. Importantly, we also want to achieve minimal ellipticity in the proximal branch too, as we believe this gives the best flow dynamics. Most of the audience will understand why we do pot, and of course the main reason is to optimize this result in the main branch, to increase the area and reduce malapposition. But I'm also going to talk about the role of pot in preventing guide wire tracking behind the stent during recross, which is an important consideration when we consider the risk of longitudinal distortion of the stent, and then focus a little on this question of how we reduce obstruction to the side branch. So pot is the inflation of a non-compliant balloon just proximal to the carina. It's designed to optimize expansion in the main branch and push struts across the side branch orifice. And you can see that in this cartoon generated by the European Bifurcation Club and published in Your Intervention. We're ultimately trying to deploy the stent optimally with the branch of the stent, so the edge of the stent moved across the side branch, as you can see here. So why do we kiss? Well, everybody in this audience knows that we're trying to recreate the carina and prevent carina shift. The mechanism of carina shift is seen in this elegant intravascular ultrasound image generated by Dr. Koo. So that by kissing, we recreate the carina. However, if we do that too aggressively, we can generate this bottleneck effect illustrated by Nick Foyne and actually get main vessel proximal edge malapposition, as you see in this OCT generated by Professor Murasato. So that with final kissing, we risk deforming the main branch lumen and ended up with an overexpanded asymmetric overstretch. The main branch lumen may be oval rather than elliptical, and there is this risk of proximal main branch under expansion. All of these we wish to avoid. So proximal pot on the bench looks like this. You can see the main branch fully expanded and the side branch orifice seen beautifully in this microradiogram generated by Francesco Burzotta. So far so good. Pot's clearly a good thing in the main branch. But what is repot versus pot? What's final pot and procedural pot? Well, procedural pot is used to prevent guide wire tracking behind the stent during recross. This is obviously going to be crucial, particularly in a two-stent procedure. And this is a way of avoiding longitudinal distortion. Ultimately, we're looking to reduce obstruction in the side branch too, and I'm going to talk about that in a second. But using pot during the procedure and making sure that that pot is done accurately was nicely demonstrated in this paper in Euro Intervention, where we saw the importance of a distal wire crossing in a Colett stenting technique and the use of OCT to demonstrate where the wire is and prevent stent deformation. So this issue of optimization of side branch scaffolding, let's look at that now. Where should the final pot balloon be placed? In the left-hand side, you see a cartoon of the pot balloon. I'd like you to consider, is that position too deep? In order to achieve what we want on the right-hand side, where we can see that the diameter of the side branch stent needs to be different to the diameter of the main branch stent. Francois Derame and his group have done a lot of work on the optimal sequence of potting, and this important paper in Your Intervention illustrated the potential advantages of a pot side repot technique. And you can see in the cartoon on the left-hand side the sequence that they used. Careful OCT was used using this sequence of procedures, and it demonstrated in 106 patients that using the pot side pot technique, you could reduce side branch obstruction, have less malapposition, and improved ellipticity using their technique. And I would ask you to note where the final pot balloon is in cartoon E. You can see it's really quite distal. They're now taking that technique into other centers, and the Cabriolet study will look at 500 patients using this repot technique to see whether they can reproduce these results in a larger patient cohort. Within the last year, there's been a number of bench studies looking at this issue of the distal position of the pot balloon, where the shoulder of the balloon should be. There's a paper by John Ormiston and his group, paper from Francesco Burzotta, and also a paper by Derame and Gérard Finet, which I'm going to discuss all three of those papers before I conclude. So this is the paper from John Ormiston and his group. This initial cartoon looks at the consequences of a proximal wire cross, and it shows that when the wire crosses proximally, as you can see in the third panel there, that the final pot actually will reduce the side branch orifice size. So accuracy with regard to the position of our cross is important, but as importantly is the position of the pot balloon. And you see that nicely in cartoon A here at the top. You see the distal recross, that actually the stent is being pushed across the side branch orifice, reducing the side branch orifice as a consequence. This is in comparison to the cartoon in B, where you see a more distal position, and actually the side branch orifice is marginally improved, or at least preserved. And when we look at a series of those procedures in the graphic on the right-hand side, you can see that the distal pot position resulted in a 43% reduction in the side branch area as compared to the more proximal position, which preserved or slightly increased it by 4%. Francesco Burzotta and his group have also looked at this same question, looking at the traditional pot position, a proximal pot position, and a distal pot position. And you see that on the right-hand side, the consequences of where that scaffolding is across the side branch. Ultimately, in this bench study, he concluded that a mid-position pot was optimal, with the balloon marker preferentially placed at the carina cut plane, and that this was the best way of preventing obstruction to the side branch orifice and also obtaining the best elliptic ratio within the main vessel. Finally, Fine and his colleagues have looked at a similar technique using an experimental bench study, looking at proximal, mid, and distal pot, and concluded that the shoulder positioning during pot was crucial, which is what we've been talking about, and that the best position for the pot balloon was the carina cut plane. So how should we put this all together? Well, ultimately, it is clear that there's a nuance here. There's a bit of debate, but I have to say that if I can't decide where to place the pot balloon on a cartoon or on the bench, how possibly can I be that accurate in a three-dimensional heart which is moving all the time? So I personally feel that this risk of too distal a pot needs to be considered, and clearly we need to spend more time setting ourselves up to get the proper geometry of the vessel organized so we can see where the balloon is relative to the bifurcation before we do our pot, and I suspect that that is underappreciated in many labs. Importantly, we need to make sure that our pot balloon is long enough to optimize the stent proximal to the bifurcation throughout its length. I think we commonly underdilate the main branch proximally, and that should obviously be avoided. But I hope I've illustrated to you the debate about the pot position, and that from my perspective, potting too distal is not likely to be beneficial. So finally, the take-home messages. The result in the main branch, in my opinion, is always going to be more important than the result in the side branch. Pot should be part of every bifurcation interventional technique, including a single stent, and that is the best way of us respecting the fractal geometry. In any two-step technique, procedural pot reduces the risk of abluminal wiring, and we should do it. In a Colett, there'll be 3 pot procedures, which makes the Colett procedure safest, and 2 in a DK crush. And for final pot, especially, don't pot too distally, as ultimately that's going to compromise the orifice of the side branch. Thank you very much.
Dear Chairman, thank you for the invitation to present at the ABC 2020 meeting. The title of my presentation is Provisional T-Stenting, Choices, Pitfalls and Troubleshooting. In the flow chart of provisional stenting, when the side branch result after ballooning is not acceptable, a bailout side branch stenting is required. What can happen first during the side branch stent implantation is that the stent does not cross into the side branch. This can be related to one or more pitfalls at one or more prior steps during the first pot after main vessel stenting, during side branch rewiring, and during side branch dilatation with or without kissing the balloon or with or without pot. The other scenario is an incorrect side branch stented placement after crossing into the side branch. So start with the stent when the stent does not cross into the side branch. We'll talk about the bailout side branch T-stenting in non-left main, and this is what we mean for T. T can be selected observing a favorable deformation of the stent in relation to the side branch orifice. When you do a distal crossing or you are sure that you did a distal crossing, you have this favorable deformation, and then you can do a T. And this can be informed also by careful imaging with stent boost enhancement. And the goal is to achieve this result. We recognize the deformation and you put your stent in a T fashion. So here is a possible scenario during a non-left main stenting. So after you have implanted the main vessel stent according to the main vessel diameter, you do your pot. This is a pot, first pot, but this is incomplete. This is the first pitfall that I will show you, the consequence of this pitfall. When you have this, what happens is that you have a proximal stent malposition here in this position. So what the next steps is just to rewire the side branch through the distal strut. You can take a third wire and go, and you are able to cross to the distal strut. But what happened that the wire before crossing here, it went in a very proximal aluminum rewiring was done here, and kissing balloon very close to the bifurcation, so nothing happened. You deflate the balloons, you remove the balloons, and then you do your repot as suggested and recommended by the guidelines. But what happened? When you do the repot, the side branch wire is jailed by the repot beneath the very proximal main vessel segment. What can happen? A bailout side branch stenting is required, and then you go with your stent, but the stent in the side branch will not cross because there is a jailed wire that you jail this wire with the repot. So there is a solution. Yes, there is a solution. You have to rewire intraluminally, maybe or possibly assisted by a dual lumen catheter, and try to rewire the side branch distally again. But if this is not possible, you have another solution. Just go with the balloon, dejail, create some space to cross. Then you can cross with your side branch stenting. Go here in the side branch, implant the stent in a T fashion, perform a kissing, and then a final repot to reocclude the vessel. Here is another possible scenario, the second one for non-left main stenting. The same, you do your first pot. This is incomplete, it's a pitfalls. Then you have this proximal stent malposition. This time you do a pullback side branch rewiring. You pull back the guide wire from the main vessel, and then you re-engage the distal strut. But the next step is just to, this is after rewiring, you remove the jail wire, and then you reinsert the jail wire in the main vessel. But during the rejailing, you go here, very proximal, you have an abdominal rewiring, and then the guide wire in the main vessel have this loop. You don't recognize that you are outside here in the very proximal aluminal. You believe that you are inside the main vessel stent. Then you go with your balloon. The balloon will cross exactly here, and you go to do your kissing as before. You don't recognize that you are abdominally here. You perform your pot as suggested by the guidelines, but after pot, what happened? That the proximal stent, because you did the pot on the main vessel, is crushed by repot here. And the side branch wire is jailed inside the crushed, very proximal main vessel stent segment. If something happened and then you have to do a bailout side branch stenting is required, what happened? Then the stent will not cross here. And if you push or pull too strongly, you can deform more, have a worse deformation of the stent. You can catch the stent, you can lose the stent. So what is suggested in this case is just to rewire intraluminally, possibly assisted by a dual lumen catheter, and rewire the side branch distally. If this is not possible, you have to take a small balloon, 125, go inside this crash portion, dilate with the bigger balloon, and then create the space to cross in this crashed position, to reach this position in a T position, implant your stent as a bailout, do the kissing, and finish with the final pot. But this time you have to pot on the side branch guide wire. Otherwise you recrash again everything. For left main is a different animal. Two examples in this case. The angle is favorable, as you see, and this is favorable to do a T stenting. So I'm talking about pitfall of T stenting. And T is frequently selected observing the favorable 80 to 90 degree LAD LSX angle. In addition, there is another pitfall that the proximal versus distal rewiring is difficult to evaluate by imaging in the left main. So you don't know if you are distal or proximal by imaging. So first scenario, you have, as before, you do after ballooning, pot, you have a side branch result after ballooning is not acceptable, so you have to do a bailout side branch stenting. But what happened? That the stent in the side branch does not cross, stops here. What can be the problem here is possibly, most of the time, a proximal crossing. But if you do a proximal crossing, what are the consequences of this? That this proximal crossing is followed by kissing balloon dilatation. You create this deformation in the main vessel stent, but then this is followed by a repot. And if you do a repot, as suggested, as classically complete repot, what the result is this. So you reposition this part of the stent against the side branch guide wire, and you jail again the side branch guide wire. If a stent is required, the stent will not cross. So what to do in this case when the stent will not cross after kissing a repot? Just do a side branch balloon redilatation with or without kissing balloon, and then go with your stent because the stent will cross. So avoid to do another repot. So the 2 points here, the pitfall was the proximal rewiring and the repot, because the repot creates this jailing. You close again the door, and my suggestion is just you have to avoid this first spot. So in any case, after provisional, probably only a proximal repot is safer in any case, because if you are unable to judge if there was a proximal or distal, this is the safest way to plot. Another case similar, the second case before my presentation is when the side branch stent doesn't cross. In this position, what is the reason possibly? Maybe there is a longitudinal stent distortion or a very proximal left main abluminal wire. And this is due to the fact that the orifice, the ostium of the left main, is not parallel to the aorta, but is oblique. So when you put the stent at the ostium, one part of the stent is protruding, and you can damage this part. You can crash using with the guiding catheter attraction, or during removal of the balloon. There are very many mechanisms, or simply rewiring. You rewire abluminally. So if you are abluminal, then you have this problem, doesn't cross, and the solution is just to rewire intraluminally, again assisted by a dual lumen catheter, try to rewire the side branch distally. If this is not possible, then you have still the possibility to rescue, do a proximal strut balloon dilatation, open a space here, and then go in the side branch with your stent, put the stent in a T fashion, and then do this bailout stenting and all the other procedures. Finally, there are 3 cases that I want to show you the incorrect side branch stent placement after you are able to cross in the side branch with the stent. And this is when you are too distal, stent deployment. This is due to cardiac motion, the presence of calcium here, or stent restenosis. What happened that the stent slips down when you are inflating the balloon at the stent in a T fashion. And so here the solution is just to put another stent in the side branch ostium, which is anchored to the first one. To prevent this, just prepare the lesion with a scoring balloon, cutting balloon, or you can do a rotablator, or do an OPN, do a lithotripsy, everything that can help you to prepare the side branch lesion to avoid this distal migration of the stent. The opposite is when you have accidentally too long protrusion inside the main vessel. This is mostly due to cardiac motion, and the solution in this case is to just convert in internal crush. When you have an extremely long protrusion inside the main vessel, with the side branch stent reaching the proximal main vessel stent segment, the only solution is this is usually due to cardiac motion, is just to convert in a mini culotte. To avoid this, excessive cardiac motion consequence, what I suggest is the balloon-assisted side branch stenting. So inside the stent, you inflate in the main vessel stent a balloon inflated at low atmosphere, 2 to 6. Then you have already placed the stent, the T-stenting that you intend to implant. At this point, you pull the stent. You can manage the pressure, reduce the pressure, increase the pressure based on the motion. When you have reached your position and everything is stable, you inflate your stent here, and then you have the result. This is what Dr. Bhagwat from India presented in the last bifurcation meeting, Indian bifurcation meeting, and this is their experience on 30 patients. Thank you for your attention.
So, dear friends, dear colleagues, it's a great pleasure to be a member of this, to be faculty for this, I think, very important session. So, and TAP technique is very popular in, at least in Europe, and as a basic technical approach during the interventional treatment of coronary bifurcation lesions. So the TAP allows us to stent the side branch as a bailout option, or we can go also by elective side branch stenting using TAP stenting technique. And definitely the bifurcation angle plays an important role in the primary decision making. We have to decide if we have to do bailout, perform bailout for the side branch stenting. So usually we have, in majority of cases, we have option to use TAP or Colett technique. And today the focus is TAP stenting, and you see there is of course option to achieve a gap in the side branch ostium, or to have too large protrusion with a long neocarina, metal neocarina. I think this is important point. And usually if we go now with side branch stenting after usually prodilatation and kissing balloon maneuver, if we have here side branch dissection or TIMI flow below 2 or residual stenosis more than 75%. So the next step will be to place the stent, and we have to, according to the complete coverage of the ostium, of the side branch ostium, we have to try to make a kind of protrusion to cover not only the ostium according to the distal carina, also to proximal carina. So that means that we distally usually have a kind of protrusion. And to find this point is, I think, very important and very difficult. And usually we should have a protrusion of the side branch stent of around 0.5 millimeter. Please check this always in two different projection. Sometimes the stent is moving. Sometimes patients is doing just deep performing very huge breathing, some breath maneuver, sometimes a problem of coughing, and this could provoke dislodgement of the stent. And to avoid this is one option to place the balloon in the main branch. So this is a kind of stabilization for the side branch stent. This is what we want to achieve. We want to achieve that our ostium is perfectly covered by stents and there is no huge protrusion. This is what we wish to achieve. If we have here suboptimal position of the side branch stent, like this here in this example, so there is definitely a risk to achieve here a gap. This would be, of course, problematic, because then we miss the ostium maybe 1 or 1.5 millimeter, and this is sometimes a bigger problem. Or other option is the risk. Other risk is to achieve too large protrusion. So we have here 2-3 millimeters of the stent in the main branch. Side branch stent is protruded too much to the main branch, and this will be really not good Colett and not good and bad TAP approach. So how to manage this? And there is an option to do this. If we have here if we implant the side branch stent and we have definitely 1.5 millimeter gap. So how to manage this? So one option is to start again with a second attempt with TAP technique. Usually we take a shorter balloon, maybe 0.5 millimeter larger, and try again to achieve perfect position, suitable position, better position. And if this is still very crucial, if we believe this could be very difficult, I would suggest, and this is my approach in our center, that we just go with stent from the side branch to the proximal main branch and make prolong the stent, make pod rewiring close to the carina, final kissing, final pod. And this is a very suitable option to manage such situation in good way. And other option is if we have a long protrusion, large protrusion, and we implanted the stent and we see that the position is really not good, we usually can remove the wire, crash the side branch stent. This is usually 1 to 3 millimeters distance, so we can crush this and perform pod rewiring, final kissing, final pod, and this is again quite good option to manage this correctly. And the problem is sometimes, like in this case, that we have here really difficulties to find optimal position for the tap. And what is very, very useful is stent boost or clear stent function, which is now a standard function in many cath labs. So you can use this technique, this function, to achieve perfect position for the side branch ostium stent. And as you can see, you can achieve quite acceptable result using this function. So in summary, TAP is still, of course, a standard technique. Post-dilatation, kissing with NC balloons is definitely obligatory. Imaging in form of IVUS, or especially OCT or clear stent function, are very useful. And in case of large gap or large protrusion, please use a retap. This one option. Second option is conversion to Colett or conversion to mini crush or nano crush. Thank you and stay safe. Thank you. Bye-bye.
Attention.
Dear Chairman, thank you for the invitation to present at the EBC 2020 meeting. The title of my presentation is Provisional Culotte Stenting, Pitfalls and Solutions. Let me illustrate first with a case that I did now a number of years ago, a complex dominant circumflex bifurcation in a gentleman in his 70s who presented with an acute coronary syndrome, which we elected to treat with provisional stenting of the main vessel. But it soon became apparent that the large side branch would require treatment as well. I don't want to focus too much on this. The side branch, after crossing pre-dilating, was stented. And then what I would like to focus on is the high pressure inflation across those struts back into the main vessel to completely open the struts into the main, and then a low pressure final kissing balloon inflation, ending up with a very nice result. So indeed, we know that clinical results can be achieved that are excellent, as evidenced by Miroslav Ferencz's study in the BPK2, in which 300 patients were randomized to provisional culotte versus provisional TAP stenting. And as you can see from the clinical results at 1 year, target lesion failure occurred in just 6.7% of patients randomized to the Colett stenting procedure. Well, there are potential pitfalls, of course. We may have the ability to rewire the vessel at the time of the decision to proceed to two-stent strategy, or to advance a balloon or a stent, or we may end up with a poor opening into the side branch ostium, and there are reasons for that. And finally, there could, in fact, be proximal vessel malopposition if we're not careful about our choice of technique in too much of a size mismatch between the proximal main vessel and the side branch we want to treat provisionally. So the first, the inability to recross with a balloon, is illustrated by this case report by Demaria, Carbanda, and Banning a few years ago, in which an 80-year-old gentleman with an acute coronary syndrome and very heavily calcified bifurcation was treated with rotational atherectomy and Colett procedure, but inability in the end to actually recross with the balloon and achieve an optimal result in spite of proximal optimization with a 4.5 millimeter balloon. But we see here that this is indeed not a 4.5 millimeter diameter, this being 3.5 in the proximal LAD. So the patient returned 2 weeks later with another acute coronary syndrome, and the ostium of the circumflex was felt to be the culprit here. They rewired again, this time with a rotowire, and rotablated, ablated the metal into the ostium and achieved a very acceptable result at the end. So we do need to remember that the main vessel diameter should be, if we're not using imaging, 0.678 times the combined diameters of the daughter vessels, according to Finay's formula in an elegant study that was published back in 2007. So inability to rewire could be related to inadequate lesion preparation. For this, we need to do proximal optimization technique till we're blue in the face if you wish. And again, we want to achieve this diameter if we don't have intravascular imaging. Position of the pod balloon is also very important. So you have to know the characteristics of your balloon and how it relates to position. So here is a non-compliant balloon with a relatively short shoulder and a marker that's just at the proximal edge of the shoulder. Here we have a balloon that also has a similar shoulder, but a marker that's quite proximal to this. So you have to know this to achieve the best results and make sure you don't compromise, for example, the ostium of the side branch when you're ballooning with the pod technique. So this is an optimal position. I would say that gives us the best opening into the side branch and best ability to rewire, and as well as to deploy balloons and stents. So if you go at an angle like this, you may have difficulty. However, if you've optimized the angle of that ostium with a pod balloon with a shoulder in this position, you will in fact make this much easier to rewire and to pass other equipment, balloons and stents. Finally, we could have, again, problems with lack of preparation. This may require cutting balloon even at this stage, or lithotripsy or rotablation through in the proximal portion and into the side branch. We could end up with a bulky neocarina, so a very poor opening into the side branch. This is usually related to where we wire the vessel, either at the proximal or at the initial stage when we're rewiring. For the provisional approach, if we rewire too proximally, we'll end up with a bulky neocarina, and we'll further exacerbate this when we're in fact wiring the second time around. So here is a very proximal rewiring. If we inflate our balloon here, we'll end up with more bulk in the carina. However, if we wire here, we end up with a very nice result in the ostia of both the side branch and the distal main vessel. The balloon position during the final pot inflation is also very important. So this was a nice model study done by Andreasen and colleagues, John Ormiston's group with Niels Holm, in which they showed that if you had a pot with a balloon across the carina, whether you had distal wiring or proximal wiring, that you had much worse opening into the side branch ostium than if your final pot was more proximal. So across the carina, very poor result, and proximal pot with much better, no restriction in the lumen. So we'll demonstrate that here. If we in fact shift this balloon to here, we end up with this result. This is a nicer opening, much better opening with a proximal pot position than across the carina, up to 70% reduction in the diameter or in the opening of the vessel. Finally, we can have proximal vessel malapposition. Is there in fact a size mismatch? Should we ever consider, if we need to do provisional stenting technique here, should we ever consider Colett here? I would say no. This is at most a 2.5 millimeter diameter vessel, and by Yves, we found this proximal circumflex to be 4 millimeters. So Colett would not be the right strategy, right technique for this particular. So in this regard, you also have to know the characteristics of your stents. These are the various stents from publication from Eng in 2016 and what their maximal cross-sectional diameter area is. This is a 2.75 synergy, for example. You can only take this to 3.6. Resolute onyx, for example, here, 2.5 millimeter resolute onyx can go to 3.3 millimeters. So in the case of our vessel, really the Colett would not be the appropriate strategy. So to summarize, Colett is a very reasonable, good bailout 2-stent strategy when a single stent provisional strategy has failed. You need to prepare the lesion well, the side branch ostium, the proximal vessel, both of these need to be optimized. This may require plaque modification. And finally, we need to end well with a double kiss and a well-placed pot. Thank you very much for your attention.
So, dear Chairman, it gives me great pleasure and thank you for the kind invitation to join you to discuss pitfalls and troubleshooting in bifurcation. I've been tasked with discussing DK crush. My name's Tom Johnson, a cardiologist at Bristol Heart Institute. So it's really interesting, I think, to look at the impact that the REVAS guidelines of 2018 had on 2-stent bifurcation technique choice. And really, it's at this point that DK crush was adopted widely as the preferred option for bifurcation. And yet, actually, the guidelines were specifically highlighting its preference over provisional T-stenting in left main intervention and only gave it a class 2B recommendation. So may be considered rather than must be considered. And that stemmed really from the excellent work from China, Chen's group, this DK Crush 5, a comparison of provisional against DK Crush in left main, highlighted the superiority of the DK Crush technique in Chinese hands, expert hands. And really the greatest benefit was seen in complex lesions. So where the side branch, the circumflex, had a lesion length more than 10 millimeter and a very severe diameter stenosis. When we look at the DK Crush 5 cohort, it was highly complex. 44% had a syntax score in the upper tercile. The provisional group converted to side branch stenting in almost a half of patients. And yet, despite that complexity, only just over a quarter of patients had image guidance. When you look at the further differentiation of these cases, complex bifurcation was a third of all cases. The side branch length for stenting was extreme, 30 millimeters in both the provisional and the DK Crush arm. And then we had a stent thrombosis rate in the provisional group of 2.5%. And so there's been a lot debated about the standard, the quality of the provisional stenting that was undertaken. Now, my approach is I do use DK Crush, but really in only a very small subset of patients. It's a very useful technique, but it is highly complex and not for everyone. I'd reserve it for left main, and then also where particularly there is a significant caliber discrepancy between main vessel and side branch, and where there's a high jeopardy, where I think there's a high risk of vessel closure. And I'll show you two examples. This was an anterior STEMI actually just from a couple of nights ago, 10 o'clock on a Sunday evening, anterior LAD occlusion. We see the LAD reopen with wiring and ballooning, converted to a 7 French radial approach with wiring of all three limbs, the LAD, high diagonal, and circumflex. And through Yves' guidance, acknowledged this discrepancy in size. The LAD, in fact, measures around 3, the diagonal 4, the left main 5, 5, 5 at the ostium. And this poses quite a challenge because actually when we consider our stent matrix, there's often this shift from the 3 to the 3-5 device. And yet we will need a 3-5 device to achieve the expansion required in the left main. And so the first important thing is to acknowledge what our stents can achieve. Now, I'd ordinarily adopt the culotte, but my only concern in this trifurcation anatomy would be a double layer of stent across the circumflex I'm planning to treat provisionally. And so actually the DK crush becomes preferred in this unique scenario where in fact we may be able to maintain freedom of struts across the circumflex to just a single layer. We overcome this disparity in terms of stent oversizing through crushing the side branch. But there then is an interesting debate as to whether you consider the LAD or the diagonal as the main vessel. An alternative consideration, I've said, is vessel closure. And this is a patient in their 80s presenting with a non-ST elevation infarct. This angiogram was undertaken. They were subsequently turned down from surgery. And in fact, when they came back for a procedure, we found the circ was closed. It opened relatively easily, but Yves then shows a very high burden of calcific disease. It's really important if we want to achieve results competing with surgery that we ensure the side branch patency. And so lesion preparation is critically important. And here I took an approach of 1-5 and then 2 burr to effectively debulk that very high grade calcium. And this is what we're left with angiographically, and we'll return to this case a little later in the discussion. In terms of pitfalls and troubleshooting, once we've elected to choose DK crush, there's been a fantastic manuscript published just this year by Manos Brilakis' group and a couple of the EBC board members. And they highlight a number of areas that I'll expand upon now. The first being failure to deliver the side branch stent. And I've already through that second case alluded to this need for very aggressive lesion preparation. And here actually we then had to also debulk the LAD. And beyond that, actually often in my practice, I will adopt then a cutting or scoring balloon following rotablation to ensure that we have got adequate expansion of both side branch ostia. Beyond that, then we have to consider the placement of our side branch stent. And so we've already considered this in relation to this first case that I highlighted, where there was an anxiety about jailing the circumflex. But actually, if we're too distal in our stent placement, we risk not fully closing the stent across the ostium. And so in theory could wire the true lumen of the stent and convert this back to a TM protrusion. So then we might want to bring the stent more proximal, but then becomes the concern that we're going to jail the circumflex. And my first tip really would be to consider using alternative projections. So here we see in the areocranial projection, separation of the circumflex and that high diagonal branch, and the ability then for us to place a stent very accurately across the LAD, ensuring that we effectively crush. Beyond that, and this isn't really touched upon in Manos's manuscript, is I think the essential need to appropriately size the crush balloon. Returning, back to case number 2, in the actual fact, in this scenario, I did adopt using the LAD as the side branch, so deploying the first stent into LAD following rotablation of both limbs. And here by Yves' guidance, if we consider that deployment of a 3-5 stent into really a very large left main, and then the first crush with the 3-5 balloon sized to the circumflex, we haven't crushed the stent. And so it's essential then that we choose a balloon that's appropriately sized to the left main to achieve crush. And that really is a very important thing to consider. That's been beautifully highlighted from the Visible Heart Lab, and this case from Paul Iazzo's group in Minneapolis, collaborating with Jens, Goran, and Francesco. And here we see a 3-5 balloon crushing a 3-0 side branch stent. And actually when that balloon deflates, we see quite aggressive recoil of the device. And then we can clearly understand how we might be able to rewire down the true lumen of the stent. Beyond that, then we have to be mindful about wire recross. And here back to case 2, where I've crushed that 3-5 device across the LAD and now trying to rewire, we see that it's very possible to wire through the back end of the stent. And in theory, as John Ormiston's shown beautifully in this micro CT example, we pass outside and then back into the stent lumen. And in doing so, then potentially create a scaffold gap. And this is something that really can only be overcome through very careful manipulation of the wire. And then often I will use a used balloon and check its passage to give me confidence that I truly have passed into the stent appropriately. Beyond that, I think there is an essential role for imaging in defining this. And then we move on to a sequential high pressure kiss. Beyond that, there are issues in terms of failure to recross devices. We're using lots and lots of stent in potentially complex disease. The beauty of a two-stent approach is it facilitates the use of an anchor balloon. I haven't got time to show you an example of that. And then beyond that, we have to take a very, very cautious approach and fastidious approach in terms of effectively undertaking pot, re-kissing, re-pot, effectively sized by image guidance, I would hope. And these are the outcomes that were achieved in both these examples I've shared with you through Yves' guidance, but really getting fantastic results and incredible MSA in all elements of the bifurcation. So in summary, I'd highlight that really DK crush is an excellent technique, but not for every patient, and I don't believe for every operator either. It's well suited to left main, particularly where there's a risk of vessel closure or we have significant size discrepancy. I think debulking and lesion preparation are critically important for the success of all two-stent techniques, and image guidance plays a really key role. I thank you for your
Thank you, everybody, for watching all these startup videos for the discussion. And now we will have 25 minutes for discussion of all these interesting cases. And just an opening remark would be that the EBC has always been very, very keen in having the definition correctly and set a standard set of discussion for the collaboration all over the world. And again, going into the first of the presentation, the provisional pathway and the philosophy, we need to address that when we put in a second stent in the initial first stent, it's not a bailout stenting. It's just more stepwise development towards a two-stent procedure if needed. So not a bailout, but a chosen thing based on the philosophy to keep it as simple as possible and stop the procedure when it's possible to stop it. So just to have this totally underlined. And having said that, I would actually open the discussion on how do we improve our toolbox and what do you have of opinions of the pitfalls we have seen and how to address them. We have had plenty of examples, but let me hear. Do any one of you like to comment?
So perhaps I will just have a short comment on the equipment and tools and all the gear now we use both in CTO procedures and bifurcation procedures. So what I observed recently, the more and more usage of dual lumen microcatheters, which we started using mostly for CTO bifurcations, but now, as we can imagine, and we also saw some presentation, we may use more and more dual lumen catheters, both for regular wiring, also for the reverse wiring of the side branch. It's otherwise, without dual lumen catheter, the use of reverse wiring technique is not safe because it will be very difficult and risky to position this fancy reversely looped wire into the main vessel to reach for the side branch. So what I observe in my lab, use more and more dual lumen catheters, especially now we have very low profile catheters, very easily used also through 6 French catheter, 6 French guiding catheters, which really, and they are not as expensive as in former times. As for the flexible tip catheter, they are rather bulky, and if the lesion is tight, you can believe me, it's not very easy to use this kind of catheter. That's why if we can do the bulking, that's great. This also has been shown so far. with a large burr to not only to break the calcium, but also to debulk, to remove the calcium. And then I will reach for dual lumen and try to wire the side branch.
So actually what you're discussing here is actually that if we need to prepare the vessel, we need to do it before we put in the stent. So the problem is actually that if we are in the middle of the procedure and face a problem, how do you use actually, if it's a difficult rewiring of a culotte, for instance, between step 2 and 3, would you use a dual catheter there, or would that be too bulky? Or
the dual catheter will not be too bulky, but in the majority of cases, if you cannot rewire, it's just the issue of stent apposition. So either I will start with larger pots with larger balloon, or I will take the Yves catheter and check what's going on, because in majority of cases there is just one of two struts are malapose, and you get your wire under the struts. The best thing to do is to use OCT and to look at the 3D image reconstruction. Then you can clearly see that some part of the stents are rewired. The wire went under some struts of the stent. So when I use dual lumen catheter is for this mostly for difficult takeoff of the side branch and tight stenosis, where these deflectable tip catheters are very difficult to use.
Well, let me ask you: you did, I mean, the use of microcatheter in your regular activity, I mean, or just for challenging cases?
No, of course, for challenging,
Oh, okay, challenging case, yeah.
19% of cases, you just do it.
Yeah, absolutely. That's what my intention, I mean, yeah.
You nicely showed how to shape the wires. Sometimes you need to put two bands, the primary and the secondary band. You can use, more slippery wires. I have good, experience also with not very stiff CTO wires like Ultimate or Miracle Bros, which is the old generation. Not to be very aggressive to avoid dissection. Yeah? But if it does not work, then I reach for dual lumen catheter.
I think the only caveat to that would be the understanding that using a microcatheter dramatically alters the tip force of any wire. So we saw beautifully in Adrian's Abbott presentation a bit earlier on, Carlos Colett using, I think, a Gaia first through a microcatheter to get into a very challenging side branch. But the only cautionary note there would be the greater risk of creating injury and subintimal passage in the side branch, I think.
Yeah, that's, I mean,
check that I think pot and optimizing as best you can, preparing before, would be preferred over having to use these escalating strategies.
I have to agree, and I think we probably have tended to undersize the pot balloon. So I think if you use Finet or if you use imaging, probably IVUS even more than OCT, you'll end up with an appropriately sized balloon for the pot. And also you have to do the pot in the right position, as I said in my presentation, so that you actually change the angle, you optimize the angle of re-entry into the side branch. I don't find at all when I do these steps that I have trouble rewiring in a provisional approach or in any approach for that matter. I don't do a lot of culotte, but
Vlad, I think this is an excellent comment, because I would like to actually change the direction of the discussion a bit to the tools we have as first choice when we face a difficult side branch wiring. So that could actually be to consider that the pot balloon was too small in diameter, and maybe just do a better job preparing the stent in the vessel. And I would like to address you, Adrian, because you pointed very well out in your presentation the usefulness of pot and the usefulness of pot in different situations. So could you comment a bit on that?
Yeah, I mean, I think one of the things that DK Crush has is it has a very predictable sequence to it. And therefore you walk, as long as you remember the sequence and you walk down the sequence, and Tom very elegantly pointed out where there might be challenges, but broadly you end up where you expect to be. I think with a provisional approach, particularly in a complex case, there are a number of decision points that you need to approach, and a number of decisions that you need to make as you go through it. And I think that therefore does not lend itself as easily to inexperienced operators, particularly people who are not used to doing a provisional approach. So I think when we look at the comparative outcomes, I think these factors are important. Now, if your pot is too deep, it may be one of the reasons that you make your procedure more difficult. And I think actually we spend insufficient time considering the main branch, and probably too much time considering the side branch. And when we're looking for that final result, I think the other point a number of people have made is that the pot of the main branch stent more proximal to the bifurcation is often underdone. How many times do we see in live cases when they do the IVUS, or perhaps more importantly the OCT, that the main branch stent is dangling in the main branch, and they haven't quite optimized that point. So I think we really must make absolute care over the main branch stent that we've actually done a good job there, and not get distracted too much about what the diagonal looks like in an LED diagonal example.
Yeah, well, but again, excellent comments, because what we have balloons, and we have things to do with the balloons if we face problems. So that might be the first step, and then consider the main branch, which is the old good-fashioned way of doing PCI. So I really like that perspective. But I could we have been touching a bit upon the need for proper vessel preparation before. And Tom, you actually showed us very well cutting balloons, road ablation, and what do we actually do, Tom, if we are caught without the preparational work and then are not able to open up the balloon? Could you comment a bit on that?
Yeah, well, clearly that's what we want to avoid if we can. And so for me, unexpectedly, I'll highlight the importance of imaging up front. And so I think that has to be something that we do more of. And we'll touch upon that again tomorrow in the session on left main imaging. I think if you're in the position where you have not adequately prepared, but you've placed a stent, then clearly your options are limited. But with now the advent of IVL, we do have a solution when we're faced with calcium.
Yeah.
And so either in the acute or the late setting of late stent failure as a result of underexpansion, then we could potentially adopt IVL, albeit with disruption of the stent that's been deployed, and then the question about whether you deploy another stent or whether you would apply drug by a drug-eluting balloon. All of those are up for debate, really.
Could you actually explain a bit more what IVL means?
So sorry, it's a shockwave lithotripsy. So clearly to try and disrupt the calcium.
Yeah, which is an option when we have put in the stent.
Yeah.
Well, actually, I would say that lesion preparation, of course, is the first step in any stenting. And you might have much more details with intravascular imaging. I think intravascular imaging, at least in left main, should be mandatory every time before doing anything in left main. That means stent should be the last step to put after you have prepared your lesion. Otherwise, you'll have some problem every time, under expansion, malapposition, and you'll make your procedure more and more difficult. So I think starting with good details on your lesion by intravascular imaging, and then prepare your lesion as well as you can, and then go ahead with your strategy.
Keep it safe, as you say.
Yeah, absolutely.
Yeah, but there is actually a dilemma in this. If we promote the provisional strategy, it could be difficult to access the side branch if we have been too aggressive in dilating it before we put in the first stent. So what you are saying is actually most applicable if you go for a double stenting technique from the beginning. So that is actually one of the dilemmas we have to face. So there is a choice. Should we prepare the vessel properly before we embark, or should we go in between? And there, I think lithotripsy has actually helped us in that perspective. But again, I would like to actually point to another part of the discussion, because we have seen so many beautifully intravascular visualization of the stenting techniques from the Visible Heart Institute, and it has learned us so much. And I would like to address a question to Professor Yves in this respect, because the model is actually healthy swine hearts. And now we're discussing lesion preparation. So all the nice pictures we have seen from the Visible Heart Lab, does that really take into account the calcified vessel, the tortuous vessel, and the stiff vessel by reshaping and connective tissue? So Professor Yves, do you have a comment on that?
Yeah, so thank you for addressing that. And Jens and Tom, thank you for including some of the visible heart footage for both the DK crush and the provisional pathway. I think it really shows, really points out a lot of what you're talking about. The other piece of it too is just that, yeah, for our the swine model is that we have, the compliance of the vasculature is going to be that of a healthy swine heart. There's not a lot of tortuosity. But we do have the option to reanimate hearts that are human hearts that are outside of the body. And so in that case, we can look more into the lesion preparation and try to really understand the vasculature of the human anatomy in that way.
So I think I would add to that, and I had the opportunity and the pleasure to actually do the DK crush with Tinnen back in October. I think that's probably is in their slide set, because I remember the exact steps that are actually in that I performed. And what it gives you is what's possible and what's needed once you've optimized the vessel. So I think, Jens, you're absolutely correct. These are normal vessels, but I think our job is to make them as close to that as possible with optimization and with preparation before we get to that step where we're deploying the balloons that we deployed in that living heart model.
Yeah, yes. Well, but maybe we should again direct the discussion a bit to the technique when we face a problematic situation in the middle of a stenting procedure. And Remo, I would like to turn to you now, because your presentation actually showed us a lot of the problematic things when we are in and out, the stent struts and all that kind of things. And directly, I would like to discuss how easy is all the ballooning and all the manufacturing of the troubleshooting you showed us? Because in most situations, it's actually quite cumbersome to pass the balloons and get them in the right place, especially if it's a calcified lesion.
Yes. I showed you the different scenario that I experienced in my life. Sometimes I have difficult, I crash the stent, and so in 15 years of work, I try to figure out what was the problem. And then first of all, the pot was very important for me, because I don't know if you remember the spherical balloon. Because so I was the creator of the spherical balloon. Then when we tested the spherical balloon on the bench, we discovered that if you inflate a spherical balloon in the polygon of confluence, then you create attraction at the end. So when I used this balloon in 30 patients the first time, I noticed that this spherical balloon was creating some problem distally and proximally, and I had problem to do the final kissing. And what I discovered with the spherical balloon was that because I did this pot before, so I was just pulling back the guide wire before the pot, because the pot, it was not available at that time. It was just to put the main vessel stent, and then I engaged the vessel. I didn't know if I was proximal or distal. So when I was doing the spherical balloon, sometimes the balloon is difficult to go. So over that, when after pot, the balloon didn't cross, it was a proximal crossing. If the balloon went after pot, it was this crossing. So one tip that I can suggest you, if you don't know if you are proximal or distal, just repot and try to go with the balloon in the side branch. If the balloon doesn't cross, probably you are proximal. You did the kissing, okay? Then you do the repot. If after repot the balloon doesn't cross, you have to before doing anything.
Or your pot balloon wasn't large enough.
Yeah.
So, yeah, it was large enough, but you know, usually you can judge if it's not. Yeah.
But that's again an excellent point because we don't really know what we see. So I would actually like to
especially for left main, because left main you don't know very well in acute MI. Sometimes you don't see if you're proximal or distal.
But I would like to actually ask Professor Hikichi from Japan to unmute and then maybe comment a bit on how intravascular imaging could help us, because we don't really see these things. So.
Thank you very much. From the IVUS or OCT shows the very important point. If you choose the proximal part, the guidewire selection sometimes pop out into the main vessel, some strut. So we should every time regressing point is choose the distal point. That is a very important point. I always try to eat.
Mm-hmm. Yeah.
Mm-hmm. Okay.
So, but again, Yoshi, maybe you could comment a bit on this also, because from your experience, from the core labs and from your own practice, I guess you have seen basically most of the problematic situation we can face.
Yes, yeah. So I think the 3D reconstruction of the OCT is really feasible during the procedure.
Yoshi, we can't hear you very well.
Can you hear me now? Yes, sorry. Okay, can you hear me?
Yes.
Yeah.
I think I just want to say that the 3D reconstruction of the OCT image, for example, is feasible during a procedure. Previously, in this optimum trial, we have randomized the cases, either the angiographic guidance or the 3D OFDI guidance. And actually, all cases, we could do this 3D OFDI if the randomization was to the OFDI guidance. And we found that the approximately half of the cases, the wire was taking the distal cell, but approximately half of the cases, 45% of the cases, actually the wiring was not optimal, taking the proximal part of the strut. So I think it's if you have a doubt whether the wire is taking a distal or a proximal struts, then I think we could really utilize this technology, and it doesn't take so much time. And also to save the contrast, you just need to limit the length of the pullback, because you don't need to reconstruct all the segment, just to look at the ostium only.
Actually, I have a very small comment on what have been described by Remo, or I think that if you are doing pot, you should complete pot for all the segment beyond the in main vessel. That means you cannot just pot only at the bifurcation. If you have longer segment of the stent beyond the stent, so you have to pot it completely, and you can be guided simply by stent boost.
Yeah,
we'll show you exactly where you are. You can open your struts completely before crossing to side branch. This will avoid some of the troubles described by Remo, I think.
Yeah, well, that's again an excellent comment, that we use these basic instruments we have in the lab actually to get a larger knowledge, but also be aware of that we do have access to OCT and 3D OCT and IVUS. It may help us.
Yeah, absolutely.
Again, I would like to address some other part of the troubleshooting, because we would like to make a very nice result in the end. We would like actually to mimic biology as the best we can. And we also know that we may face some, well, not that nice results, but do we really know which of the creation we made really matters in the long run. And actually, I would like again to address Professor Iles in this question, because from your experience in the Visible Heart Lab and all your bench testing work with stents and material, do you think that maybe simulation of flow or whatever does it have a place in a better understanding of which of the problematic situations here matters more than others?
Yeah, no, I mean, that's a really excellent point. And I think, so it's kind of I think there's a lot of different routes that we can go with the simulation aspect. But in terms of just using the Visible Heart Lab as kind of like this platform where we can put stents into the vasculature, and in this case, healthy swine, or we could go and use some of the human hearts that we have in the library to do this stepwise technique. And that's something that Professor Izio and Tommy Valenzuela, one of the PhD students in the lab, have worked on. And he's actually done a lot of micro CT work to be able to capture this in a very detailed way. And then from that, we can put that into simulations where we can look at flow, look at carina shift, wall shear stress, and other parameters to be able to better understand outcomes and try to identify what might be a signal to describe best how some of these stepwise procedures will actually have what their outcomes might be, and to be able to visualize them too directly. So you kind of have all these pieces together where you can validate a lot of the simulations that way.
Yeah, so that is a way forward maybe. But if we go back to Yoshi again, I guess 3D OCT may also be an investigational tool to, in the long run, actually see and evaluate if some of the maybe not so good results actually translate into later events. Yoshi, do you have a comment on that from some of the trials that you have actually done it in?
Yeah, I think yeah, in general for the OCT or the OFDI, I think it's important to know that what is the goal you have to achieve during the procedure, meaning that what is the, for example, greater than 80% of the minimum strength area, or the 80% of reference lumen area. And in terms of the ostium of side branch, we have a software which enable us to look into the ostial cut plane, so that you can really measure the ostium from the main branch curva. And I think probably that measuring the side branch ostial area might be helpful to predict the future event, or just to see that the opening is really okay for the side branch.
Okay, Yoshi, so we do have actually tools coming up which actually could help us a bit predict whether or not we should do more to optimize the procedure, or can accept it what it is. So because I would like to actually, because of this discussion, Marek, I would like to address you, because you have actually published one of the extremely impressive papers on 10 years follow-up of the TAP procedure. And if you go back to that, then again, did you have some predictors of a poorly performed TAP that actually turned out to cause problems over the years for the patients? Could you comment a bit on that?
Yes, so we do, even today, I have done today morning two distal left mains.
What was they okay, or do we actually fear for the patients after those two?
No, they are perfect. They are perfect. But the problem is what we have done for many years. What I have learned from me, from my personal experience level, we usually are too defensive with lesion preparation. And this is, as Imad mentioned many times today, this is the problem number one. So we are not really focused, or I was for for some time, not really focused on lesion preparation. Okay, 3.0 balloon, open, okay, nice, stand, and then everything is okay. And what we saw in the TAP technique,
we observed in many cases, even from BBK1 and especially from BBK2 trial where TAP was done, we saw that we still have too many gaps. So I believed in 2 or 3 different projections, I believed I'm perfect, but finally during follow-up, and then even if you do imaging, because I was not believing the result, long-term result, then in imaging you saw, or even if you use today clear stent function, you can see definitely very nicely there is some gap. And in many cases, other problem was we didn't postulate ostial side branch very aggressive. So it was just TAP done with a semi-compliant balloon, maybe 14, 16 atmospheres. But today what I'm doing, always postulatation with non-compliant balloons. And we go now more than 20 atmospheres, 22 atmospheres, 20, 18. That's the way to avoid malapposition in the ostium. And lesion preparation, of course, that's the way. What I have done a few times, in few cases, if I have still recoil, because there is a lot of plaque material, calcified plaque material, what you can do is to use IVL, as Tom mentioned, but you should know, even in one case, I was not really able to cross and damage the balloon. The balloon needs a channel, and you could, if you are too fast, too rapid,
so Marek,
damage.
So what you say is actually the same that Yoshi told us, that there are signs in the initial procedure that may guide us that may predict late poor outcome. So there are things that we are capable of by using intravascular imaging or whatever to address. And I can see that Adrian has a comment on that. So Adrian, please.
I was just going to say that, one of the problems I believe is that looking at the panel, many of us are of a generation where we've been doing this a long time, and we were brought up to try and do it too quickly. Now, there were reasons why we were doing that. It was partly to do with the practice in the lab, and we had lots of cases to do, and the kit that we had, and we were just trying to get in and get out. And I do think we've got to change our philosophy towards a perfect result. If you look at the comparisons, the syntax trial, the Excel trial, the reasons that we struggle to compete against surgery is that we didn't do a good enough job with our angioplasty. Ultimately, the procedural events were too high, but the long-term results were not stringent enough. And I do think that we, particularly if we're moving towards, as we are now, doing patients who could have bypass surgery as an alternative, surely we must make sure that we prepare the lesion properly. Surely we must image, and surely we must make sure when the patient leaves the lab that we've done a really good job. It's within our gift. And I find the fact that we don't do more of it quite frustrating, really. But I think it's because of where we came from, and I think we just need to change our heads a bit to make it happen more regularly.
But Adrian, I think actually this is an excellent concluding remark on this session, because it underlines two things we have learned over the years. But also we need to be more meticulous and more precise and much more focused on having an optimized result. But it also opens up the question, when is a result good enough? Then we face a dilemma again, not ending up in that the best is enemy of good or whatever. So if we should finalize a bit on this, I guess that we are on the right way, but we need a lot of scientific work actually to be able to identify the cutoff point of what is too poor, what is partly acceptable, what is acceptable, and what is good without going over the line. So having said that, thank you for all of you for participating in this session and participating in the discussion and put all your knowledge into this. And thank you again for supporting the EBC over the years, and again to stand up and help us actually promote all the visions and all the ideas in these virtual times where COVID actually defines the agenda. So thank you very much. And by this, we will finalize this session. Thank you to everybody.
Thank you. Bye-bye.
Thank you.
Thank you.
Thank you.
Yeah.
Bye.
Stay safe.